Yeah, thank you. And we go on to the next session. And I can welcome, I still invite the German surgeons and the German faculty to stay on for our next surgeon, which is spine surgery navigating the future. And I request Dr. Chabra, Dr. Sarjan, and myself who are there. Dr. Chabra is there? Is not there. So shall we go ahead? And I can see Dr. Andrea Luca there already. I just saw him.
Yes, thank you very much. I'm here.
Okay. So you have a great talk. I think virtual reality, augmented reality, and 3D are all coming in. And your first talk is virtual reality for remote education and future of augmented reality in medical care. If it's okay, we will start straight. Go ahead with your.
Good afternoon, everybody. Thank you very much for the invitation. My name is Andrea Luca, and I work in Milano in the Galeazzi Hospital. It's a privilege to be here today. First of all, let me thank the chairman who allowed me to stand even if only virtually in this exceptional context. First of all, I have to disclose my position as co-founder and chief medical officer of a small startup named Hypersurgery. In this brief presentation, we are going to talk about two technologies, virtual reality and augmented reality, and their application in the educational program that we are running and their use in the daily clinical practice. We would also like to share our thoughts with you regarding the application of this technology in different contexts and environments. And in fact, our aim is to make those technologies affordable, interactive, and democratic, fulfilling the applicative principle of inclusiveness and equality that allows us to break all the socioeconomic, cultural, and geographical barriers. The acronym of the program we launched is not by chance AID. Beyond the specific technical aspects that make each computer technology more efficient for specific tasks, such as training or direct clinical application, they are all closely linked, and their integration is, as usually happens with technologies, produce further improvement of the global system. This technology also offers the possibility to instantly create accurate and measurable outcomes. And this allows us to generate, and it will do more in the future, a critical mass of data, which will feed what is nowadays the superstar among all the technologies, that is the artificial intelligence, of course. Regarding specifically the VR, our hypothesis is that virtual reality can positively impact on the healthcare professional providers' performance through the improvement of their skill and knowledge that are known to be two main determinants of competence. For this reason, we built a VR training program based on the Dreyfus model of skill acquisition. Each level has its own specific pattern, thus allowing to tailor the training to the pre-existing level of expertise of the user. For example, an advanced beginner, users are primarily taught to follow a specific workflow, applying it to clinical situation, and so will do the simulator. For competent users, the simulation provides a free run procedures without any interference. The possibility to measure the final outcome and potentially identify the mistakes made during the presentation by the effect they produced enhance the skill transfer, according to us. And this is what we call learning from mistakes. In our experience, this is the closest way to learning in the real clinical setting. In this short video, you can see the simulation of the well-known surgical procedures, the X-lift procedures. The user is, in this case, an advanced beginner. First of all, has to prepare the OR according to a specific pattern. The user has to move the object in the room, to correctly position the patient, and to select the appropriate X-rays projection. Once all those steps are accomplished, the evaluation form will be displayed. And then, once the OR setting has been correctly performed, the user will access the surgical approach. We built an immersive environment with all the feedback that you can experience in a real OR. In this case, the approach is guided, and potential mistakes with their explanation are shown. The simulator will provide tricks and hints. For competent users, we planned a free run procedures without interference. For proficient users, the simulator will randomly generate unexpected situations such as intraoperative complication or anatomic variants. We tested our simulator on our residents, and the results have been recently published, showing encouraging perspective for this technology. We believe that this technology may be attractive for educational providers such as the European Spine Society and institutions with the high educational vocation like our center, Istituto Ortopedico Galeazzi, which welcome students, residents, or specialists for basic or advanced training program. But the mission of the aid campaign we launched is to make this technology available also for peripheral centers which may benefit from its educational program to ensure a quality standard for the healthcare providers. For this reason, we developed a smart suit, VR suit. The equipment is quite affordable and it's not necessary to have a large of permanent dedicated areas for the training session. In the video, I'm running the procedures at home, and it's a kidney biopsy, by the way. The simulation is preloaded in the workstation, and virtually you don't even need an internet connection to start the training session. Finally, we have foreseen the possibility to run the training session with multiple participants, even in remote modality. In this test that we ran a few months ago, the developer and I were performing a training session simultaneously from 2 different places in Italy. In the simulation, as you can see, we were both working on the same virtual room, on the same procedures, sharing the surgical tools. In conclusion, VR allows us to efficiently transfer competence through an immersive and engaging experience, simulating ordinary conditions, but more importantly, even extraordinary situations such as complication. The possibility to analyze data, the outcome to build predictive models is still under evaluation. Other pros are that this approach is affordable and if needed, it can be remotely run. In addition, this training program respects the highest ethical standards, being cruelty-free and avoiding the sacrifice of animals as happens for live tissue training. Regarding the drawbacks, for sure, to develop a single procedure is a long process and requires high professional profiles. We did not experience motion sickness, and the haptic feedbacks did not allow a full sensorial immersion in the procedures. Let's move to the second subject of this presentation, the augmented reality. Its popularity in medicine is constantly growing, as this PubMed research clearly shows. One of the potential applications, definitely very close at hand, is to redesign the medical environment, reducing, for example, the OR equipment. The surgeons may recall the patient information, including imaging, CT, MRI, in sterile fashion by voice control or gestures. In the near future, the process of redesigning the OR might go further to the point that not even the patient will be in the OR. This is in the case of telemedicine and telesurgery, with the possibility to remotely co-act with multiple operators simultaneously. We are testing its use in the spinal navigation, and several studies reported the use of AR to identify and more accurately resect tumors. And also this, according to us, sounds very attractive. In our opinion, this technology may be prerogative of Center of Excellence, which routinely deal with highly complex procedures with multiple different professional profiles might be involved in the procedures. To be honest, according to us, there is less room for its application in peripheral centers because of its costs and the need of stable and high-speed connectivity. It may replace the current tool used for telemedicine. This technology allows us to have simultaneous access to the medical procedures by multiple specialists. The hands-free control is particularly helpful in critical situations such as the operation room or COVID-positive patient department. Once again, this technology allows us to store data that can be thereafter analyzed and manipulated. On the other hand, the devices currently on the market are still somehow primitive, and the technology itself has substantial costs that might hinder its diffusion. In conclusion, a scientific approach to study the application of new technology in the medical field is necessary, both to test their real efficacy in our daily practice and to ensure the highest safety standard for the patient. Diligent scientific research approved by deputy ethical committees should be encouraged to answer the many questions still pending regarding the potentiality of this technology. An additional effort, according to us, should be made both from the scientific and political communities to ensure a wide diffusion of this technology, even in remote or peripheral areas. To make this possible, the technology should be affordable, ready to use, suitable for different socio-economic contexts. And this is exactly the philosophy behind our project that leads to a smart VR suit. It can be installed virtually in any place, allowing high standard and measurable transfer of competence, enhanced by the possibility to remotely connect specialists. Aiming for this purpose, we call upon academic institutions, public or private organizations to join us in the challenging project to make this technology available to everyone. Thank you very much for your attention.
We can take any questions for Dr. Andrea Luca.
Thank you very much.
Hello. Thank you. So, Dr. Luca, we have a capacity building program where we are trying to take up centers and with the help of mentors, have them upgrade their capacity and clinical skills. So in this era of the pandemic, I believe this would play a big role, right? So do you suggest this could be useful in also intraoperative surgical monitoring also?
That's a good question. I think at the moment the augmented reality technology is, as I said, is a little bit primitive. The device is not the best solution for its use in directly in the OR, even regarding the certification. But for sure, it will change very fast in the future. We will have better devices, the one they use, the military use, for example. So I think very soon on the market there will be augmented reality. But we are focusing mainly on the training of the surgeons, and that's why I think this is a very powerful tool that allow to give something more to our residents and to the young surgeon, even to experienced surgeon, because we can create complication, we can create new scenarios that actually you cannot find in any of the educational platforms that are already available.
So there's another question. What is the actual difference between augmented, virtual, and mixed reality?
Actually, this is, I think they are all computer-based technology. Virtual reality allows us to create a new world, create a new environment in which you can have different sensorial feedback. And this is what we think is the best for the training. Augmented reality in the technology give you more feedback from the reality. So you can, I think all of you knows Google Glass. It was in the past very, very popularized. You can see your environment, but receiving more feedbacks from the computer. And this is so you can see the reality with is exactly the more of this technology working together to give different pattern. But I think it should be clear what is goal for, according to me, for clinical application. I think augmented reality will suit better. For training, I think virtual reality is the best solution because you can create exactly what you want your user to learn.
Dr. Andrea, can I ask you something?
Please.
I last in the Global Spine Conference, I heard a couple of lectures, and there was Dr. Goel who was saying that they compared cadaveric training versus virtual reality training, and they found that the learning curve post cadaveric training was longer and people made more errors than on the virtual reality training, because you could in real time do the virtual reality training multiple times and get more accurate than you would do on a cadaver, and you never got that feel. What do you have to say on that?
Thank you very much for the question. It's great, I think, this comment. And please let me invite all of you to join us in this project. We are trying to build a big library of the virtual reality procedures. It's exactly the same. We have several advantages using VR training program. First of all, you can repeat all the time, 7 days, 24 hours, 7 days, the training. So you can access the training whenever you want, wherever you want to actually. You can do even at home if you have the workstation. But I think it's uncomparable the benefits. This is my personal opinion with cadaveric against cadaveric training, because you can not only do the procedures, let's say put the pedicle screws, but you can learn why you should do this, the setting to be the best setting to do that, the procedures, and then you can do the procedures, but you can simulate also the complication and trying to overcome the complication and the or unexpected situation. When we do a cadaver lab of scoliosis, this is what happened to me actually. I couldn't have a scoliotic deformities cadaveric spine to do that. So I put screws, pedicle screws on a straight spine. On virtual reality, you can simulate exactly the type of anatomic condition that you require to do that presentation. So I think the benefit of virtual reality are several comparing with the cadaveric. Nevertheless, we have also to consider that many times the quality of the material that you use, the cadaver, is not good enough to allow you to have a good training.
Thank you very much. I have one small more question is, do you think people younger are able to pick up these technologies better than people older are more disabled in that, or somebody like me would take more time than somebody like...
This is a great question. We investigated in our paper, we investigated this aspect because we had junior residents and we have senior surgeons doing the same. What took more was we developed a demo, a tutoring before, virtual reality tutoring. So after that, it was comparable the time needed from a senior surgeon versus young surgeons to do the procedure. So I would say no, the age or the ability to use technology is not affecting at all the virtual training. We are safe.
So another question, Dr. Andrea Luca. Do you think the virtual reality has a definite role to play in the rehabilitation of the patients?
This is another interesting option. We are testing this. I think we are using on, for example, for low back pain, we are using the virtual reality training program. I think in this case we should more take care about the one of the complication of one of the problems that you can have with virtual reality, that is motion sickness. This is something that we are studying to be avoided in the rehab patients, but I think it's going on. So even for paraplegic patient, we are building this VR room with quiet environment, and I think it could be good. The only problem might be the proprioceptive feedback, that it's not the same with virtual reality and reality. But we are testing this.
Thank you. One more last question, Professor Andrea, is that we ASSI has a membership list of 2,772 members, a large organization. So before all of us get exposed to it, are there any video games we can play to make ourselves better in training ourselves? Because my youngsters tell me you don't do any video games, you're not good in your phone, and you take so long to type a WhatsApp message.
Well,
do you
actually,
think there are any video games, or you can tell us some tricks or tips?
Actually, I was formerly a video gamer. I still do a little bit with my children, and I think the best way, if you want to really, and this is how I started. It's available on the market. A lot of not expensive VR suits. You can buy one of these and try some very easy video games. That is a Saber, for example, or there are a lot of the Eagle Eyes, and you fly with the VR. And if you don't get motion sickness, because in this video game you can have motion sickness, you will enjoy it very much. I'm doing dinosaurs environment with my children, and it's very funny. So if you want to be a good father with your children, you can play with this dinosaurs game as well.
I think, thank you, Dr. Andrew Luca. We
Thank you
know
very
you
much.
have a flight to catch, and we had to reschedule this session for some logistical reasons, and all of you cooperated with us.
Thank you
We would
for
thank
your
you
answer.
for
Thank you
joining
for your
us,
answer. And
taking the questions, and we would wish you a safe flight.
thank you very much. And please join us in the project. I think we will do a good job. Thank you very much for the invitation. It was my privilege. Thank you.
Definitely, definitely. I think we have Dr. Alok Sharan here. He will be talking on will daycare spine centers take precedence in the future?
Hello, my name is Alok Sharan. I am an orthopedic spine surgeon in New York, New Jersey, and I am the director of spine and orthopedics at NJ Spine and Wellness. I am truly honored to speak today about this topic: will daycare spine centers take precedence in the future? We have seen tremendous advancements in outpatient spine surgery here in the United States, and I know in India there have been a lot of advancements leading to outpatient spine surgery as well. So the first question is, will day care spine centers take precedence in the future? I would argue that the answer is, it already is. We've already seen that many orthopedic procedures like knee replacements and hip replacements, which are commonly performed in the hospital, are routinely being performed on an outpatient basis in ambulatory surgery centers. With spine surgery, we have been seeing over the past decade a trend leading to more and more outpatient spine surgeries. Here's a paper that was published a few years back that looked at laminectomies and ACDFs. The line in red is showing how many of these procedures are being done on an outpatient basis. The lines in blue are showing the transition from the hospital out towards the outpatient arena. So you can see how there's been a decrease in the number of these cases that are being done in the hospital and an increase in the number of these cases being done in an ambulatory surgery center. Where this hasn't really changed much is with lumbar fusions. In blue, again, are the number of cases being done in the hospital. Red and green are the cases being done on the outpatient basis. So there's still a gap over here. But as I mentioned earlier, the outpatient spine surgery has seen tremendous advancements in the last decade. Many surgeries which were routinely performed in the hospital are now being performed on an outpatient basis. This is because there have been tremendous enablers of outpatient spine surgery. Number one, of course, has been the change in surgical technique. We're seeing more and more endoscopic and minimally invasive procedures being done. Of course, improvements in anesthesia protocols have made a big difference. The use of spinal anesthesia and regional blocks have enabled many of these patients to be able to go home the same day. And even more so, there's been a tremendous acceptance by patients that spine surgery can be done on an outpatient basis. And what we're seeing now in this post-COVID period is that many patients are actually demanding for the surgery to be done on an outpatient basis. So there are many enablers of outpatient spine surgery at this time. So the first question again is it safe? Should we be doing outpatient spine surgery? In this paper that was published in 2019, Dr. Del Sol and authors looked at a meta-analysis of papers and tried to understand whether or not surgeries such as ACDFs, lumbar decompressions, and fusions, are they actually safer, or do they have higher complications when they're performed on an outpatient basis? And they demonstrated very clearly in this paper that many patients who are discharged the same day have little reported risk of complications. So for the proper patient, outpatient spine surgery is safer. Is it cost effective? Well, in the United States, the cost of doing a surgery in an ambulatory surgery center is about 50% less than when it's done in a hospital. So clearly, as costs become a major issue, moving these cases towards an outpatient center will make a big difference. And so, yes, it is cost effective. But it's not always easy to do. Doing outpatient spine surgery doesn't mean that you just go from the hospital to an ambulatory surgery center. It's really important that before you start to build an outpatient spine program, that you have proper selection criteria on who can be performed on an outpatient basis. Doing outpatient spine surgery certainly requires a lot more education of the patient. They have to understand what they should be watching out for, what they should be worried about, when they should notify you. And it becomes really, really important that when you start doing outpatient spine surgery, that you have more touch points with the patient. Because if not, the patients will have surgery, and as soon as they begin to feel pain, they'll be scared and they may even go to the emergency room, which really defeats the purpose of outpatient spine surgery. So one of the major challenges of outpatient spine surgery is having more touch points with the patient. Question then is, how do you establish a outpatient or day surgery program? Well, for us, there's been a tremendous development of surgical protocols. I perform a lot of my surgery using minimally invasive techniques and some procedures using endoscopic techniques. As many of you know, we have been performing a lot of our spine surgery awake using both spinal and regional anesthesia. So anesthesia protocols is really critical. And I think it's really important when establishing a day surgery program that you have good preoperative and postoperative coordination. It's important to have a coordinator who can do proper preoperative teaching, and perhaps the same individual can postoperatively have multiple touch points with the patient so that you can have the ability to remotely monitor these patients. Otherwise, the second they begin to have pain or have a complication, they may end up going to the hospital. But is it worth it? Is it worth going through all this? I would argue that outpatient spine surgery is the next major advancement, and that if you can achieve it, it just leads to better outcomes and better satisfaction. This is a patient of mine who we just recently operated on. She had spinal stenosis. She had undergone an awake laminectomy procedure, and we had asked her to make a video of how she's feeling 3 days after surgery, and you can see here the results.
Hey, feeling good, like I should. When in circle, walk around the neighborhood, feeling blessed.
So as you can see, she did very well with the surgery, and I think that was because of a combination of good surgical technique along with good anesthesia. And because of that, she did really well. So I would argue that awake spine surgery and day spine surgery is the future, and that if you're not performing outpatient spine surgery right now, I think that going forward, as long as you can follow certain principles, it can lead to greater patient satisfaction and certainly better patient outcomes. So I thank you for that, and thank you again for the invitation to speak today.
I think we can take some questions.
Yeah.
This is a very interesting concept.
Alok, what is the kind of anesthesia that you generally use for such patients? You're muted, Alok.
Can you hear me now?
Yeah, right.
Okay, for the laminectomies and the spinal fusions, we use spinal anesthesia, and we use isobaric spinal anesthesia. There are two types of anesthesia you can give by spinal. One is isobaric and one is hyper. So we use isobaric spinal anesthesia. In addition, we perform a regional block called a TLIP block, TLIP. I'm giving a talk later today, my time, I think it's tomorrow for you, where we go through how to perform the TLIP block. So it's isobaric spinal anesthesia, and we use the TLIP block, TLIP.
Hello, Gautam Zaveri here.
Hi, Gautam.
Hi, Alok. How do you manage the challenge of postoperative pain control in patients? And number two, a lot of our postoperative patients after lumbar spine surgery get constipation. And that's one of the problems. How do you overcome that? Those are challenges, and often when you send them home early, these patients have constipation and they keep on bothering you. What are how have you solved these problems?
Yeah, that's a great question. And that's why I was trying to highlight the challenges of outpatient spine surgery. You have to have more touch points with the patient. So pre-operatively, we start them on some type of bowel regimen or some type of medicine to make sure they don't get constipated. And then post-operatively, we make them continue. So we use Colace, for example, and they often started 2 to 3 days before the surgery and continue it for up to a week sometimes after surgery. That minimizes the constipation. During surgery, during the actual surgery itself, we minimize any narcotic given by the anesthesiologist so that they don't post-operatively get any kind of constipation. And then critical to all this is pain control, so they don't need narcotics, so they don't get constipated. The spinal anesthesia, as well as the TLIP block, when performed properly, can help minimize narcotic usage, not get rid of it, but you want to be sparing. Often they'll be taking narcotic pain meds for just a couple of days, And if you, I'm not saying all the time, but if you do it properly, you start them on a bowel regimen before the surgery and then during, it minimizes how much constipation they have.
Right. There is also a question from one of the audience, and that is, does it need a learning curve for spine surgeons to learn protocols for outpatient care or to refine techniques or learn new techniques? Do these patients chosen for outpatient surgeries, are they screened in any particular different way? And do the anesthetists also need to be trained differently?
Yeah, those are great questions. So, it's actually interesting. In my next talk, I'm going to talk about how I'm working with a group in Oxford, England right now, and helping them develop an outpatient spine surgery program. And what I recommended to them is that they first start doing ambulatory surgery on just simple laminectomies on people who are age 30 through age 50. And what you want to do is be predictable in how long it takes you to do the surgery. And so I would argue that the learning curve should start with easy laminectomies, complicated laminectomies, and then you can move towards fusion. What was the second question, Gautam?
Are these patients chosen for outpatient surgery, screened separately and planned for in a pre-admission differently? And do the anesthetists also need to be trained, talked about, do deal with these things differently? Are they specifically trained for outpatient anesthesia?
They're not specifically trained for it because most anesthesiologists are very comfortable doing a spinal. But if you have a preference, you want to start with an anesthesiologist who has extensive experience with OB-GYN cases, because they know how to give a spinal anesthesia for very complicated situations. So that to me is how I would do all that. In terms of selection criteria, I think that you just have to be careful. You have to speak to the patient, make sure they're healthy and that they want to go home the same day. That's critical because you don't want to do it on a patient who doesn't want any of these procedures. But from a medical point of view, I would argue that most patients qualify for outpatient spine surgery if you ask them the right questions.
I have a question, Alok.
Yeah.
My question is that I find that if you do a discectomy post-spinal or a mini decompression, sometimes they can get bladder retention, which they would not normally get post-general anesthesia. As we are doing a randomized controlled trial in our institution with single level discectomy with epidural anesthesia versus general, I find the ones who have an epidural anesthesia have some retention of urine. Do you have a trick or a tip how we can avoid this?
So I would consider doing a spinal versus epidural because with a spinal, it's a single shot and it's more predictable how much dose you get versus the epidural where it's more unpredictable how the medicine diffuses. So I would consider that I would first consider spinal versus epidural. Second of all, it's critical, just like I was talking about with constipation, that especially elderly men who have BPH problems, it's critical that they take their medicine on a good regimen before surgery. What I find is that if the patients skip their doses before surgery, those are the ones who have problems after surgery. A spinal in itself should not cause urinary retention if they're already on medicine. But it's the people with undiagnosed BPH or the people who are not compliant, they're the ones who typically have problems post.
So do you have a protocol? Sorry.
No, go ahead.
So do you have a protocol? Because we have instituted a protocol now that all these patients who have spinal or versus in the randomized, that they will have an ultrasound and a residual urine. So only if the residual urine is less than 50 ml would we then introduce them in this study. Do you think that
perhaps we can talk offline. I would love to help you. I can show you some of our data around that, about how we've helped with minimizing urinary retention.
Look, there's another question. Can they tolerate prone position? And if there is a complication, how to top up?
So they can tolerate prone position, but of course, again, you have to educate the patient. This is what's going to happen. I use a Wilson frame with a pillow. They actually, if done properly, tolerate prone position really well. It's almost like sleeping on their belly. So most patients can tolerate it. You just have to tell them that this is what's going to happen. And your second question, Dr. Chabra?
If there's a complication, how do we top up?
That's always a challenging situation. I think that like any situation, you have to make sure you have a bed available. The anesthesiologist would have to be ready to do a MAC anesthesia, not be able to intubate, but be able to do MAC and then be able to turn them supine. But it's a situation where oftentimes when you do general anesthesia, the tube is in and the anesthesiologist let go and they're not really paying attention. In this particular situation, the anesthesiologist has to be more involved during the case to make sure that there's no complications and they can convert if they need to.
You said that you would want to start in patients between, you would suggest that we start in patients between 40 to 50 years of age and then take more complicated cases. But would you agree that the ideal patients who benefit the most for this would be geriatric patients, especially who have cognition and dementia problems?
No, I appreciate that question, Dr. Chabra, because that's what started me on all this. I initially did a study where we looked at the rates of general delirium in elderly people in general versus spinal anesthesia. And we showed and we published very clearly, convincingly, that the rates of delirium after general anesthesia are significant, and that delirium leads to significant complications. So I would argue that for an elderly person, which in our study was over age 65, that you really should think about not doing general anesthesia on these patients. But even more so, during this COVID period, we understand the complications of intubation in general. So if you can do a surgery where you don't need to intubate them, to avoid delirium as well as avoid complications of intubation, I would argue that you should do it. And in our opinion, the elderly people are the best candidates for this kind of procedure.
Yeah, that's what I was saying, that we should start in the young patients, but the ideal patients would be geriatric patients with cognition and dementia issues, right?
Right. And then the one point I want to make is that, for example, with the group in Oxford, I recommended them to do the young patient because it's a more predictable surgery.
Right.
So it's about the issues around the surgeon, how to set up the OR and whatnot. And so we say young people because then it helps the OR staff get ready.
Thanks, Dr. Alok Sharan. Thanks for joining us and taking all these questions, right?
Thank you.
We have now Dr. Karan Singh, who will be talking on prospective application of virtual reality in improving access to quality and affordable spine care.
Thank you, everybody. My name is Karan Singh. I'm a full professor in the Department of Orthopedic Surgery at Rush University Medical Center here in Chicago, Illinois. It is a pleasure and honor to provide this talk to you today regarding prospective application of virtual reality in improving access to quality. I think we need to understand the originations of virtual reality. Dr. Furness was considered the godfather of virtual reality. It was initially developed for the United States Air Force in order to allow pilots to access avionic data. Understanding what virtual reality is, it's essentially a computer-generated simulated environment that recreates three-dimensional space. Most of the early development was restricted by the computing power and imaging processing. However, now computing is cheap and the efficiencies have opened up significant opportunities for a wide variety of applications. Video games have become the #1 trending application for virtual reality, and as technology has improved, so have other applications. Now medicine has an invested interest, in particular with education, telemedicine, surgery, and simulation. Initially, pioneering developments pushed the virtual reality platform into medicine. In the early 1990s, general surgery and orthopedics started to explore the utilization of this technology, which created new opportunities for surgeons, in particular with this application for advanced three-dimensional imaging, robotics, simulation, minimally invasive techniques in particular, as well as for telemedicine and web-based informatics. So what is the current use of virtual reality? General surgery has used virtual reality for the evaluation of surgeon competency. It's been also applied for recertification using virtual reality modules. In particular, there has been an increased interest in virtual reality for spine surgery purposes. In regards to training, it helps avoid the use of cadavers, theoretically decreases the number of hours spent in the operating room, and it can be helpful for preoperative planning as well as for procedural rehearsal. In regards to training purposes, it can extend to residents, fellows, young graduates, and even established attendings. The training program can be customized. Residents can gain familiarity with spine cases and can reproduce certain procedural applications involving pedicle screw placement. Younger surgeons can simulate minimally invasive surgical techniques to help flatten the learning curve, and established attendings can adapt new techniques using training modules in a safe environment. So where does this lead us in regards to its prospective use, and how can virtual reality improve spine care? Well, virtual reality improves training. There are low stakes and low risk, so it allows for participation in a new technique. It allows for surgeons to learn at a quicker pace with repetition. It can be applied in a specific training pattern, which can be applicable to fellows and young attendings, and allows for visualization of anatomic structures to help understand anatomy, in particular for minimally invasive techniques, and there's a significant cost savings versus cadaveric models. Virtual reality clearly improves quality of care. It allows for preoperative mapping, particularly for anatomic and for planning purposes. It increases the efficiency due to repetition, reducing errors, potentially decreasing operative time, and can overall improve the accuracy, in particular for pedicle screw placement. What about increasing access to quality care? We need to understand what the barriers to care are. Access to advanced medical care can be limited due to geography, that is being a remote or rural area. It can be limited due to the complexity of the case and the inability or difficulty with the hospital to manage that. There's also a supply-demand mismatch. There may be limited spine surgeons in growing particular patient populations. Virtual reality can help make care more accessible. Preoperatively, it can help provide preoperative assessment. Travel to multiple appointments may be challenging for some patients. It decreases the overall burden to patients. It can be integrated seamlessly with telemedicine visits, providing for a remote physical examination, evaluation neurologically, including range of motion, strength, can also with haptic technology, which allows for feedback. Reflexes could potentially also be assessed, and it also allows for immersive instructive material for patient education. It can also help improve post-operative rehabilitation. There can be an increased engagement in physical therapy, occupational therapy with the patient. There's real-time feedback. There's also a dynamic and quantitative monitoring for the examination component itself, and the potential promising application for pain management in regards to helping patients understand their current situation holistically and helping address some of the biopsychocognitive feedback patterns. There are extremely significant opportunities for collaborations, in particular shared decision making with remote colleagues, including preoperative planning, potentially intraoperative consultation, and successful virtual reality collaboration potentially have been done between neurosurgeons in Alabama and Vietnam. So this technology is definitely expanding and is being applied in real time currently. What obstacles do we face for integration of virtual reality into our current clinical practice? Well, the first thing is the technology itself is rapidly evolving. There are different systems that are being implemented. As such, standardization may be difficult. One software platform may be completely different than the other, and this may raise compatibility issues between institutions, regions, and even devices within the same institution. Let's be clear, there is a price to new technology. The cost may be passed on to institutions for the upfront cost of the virtual reality system. These can be significant, upwards of $10,000 per unit, and there are multiple units that may be required depending upon the number of surgeons and the frequency in which the technology is being utilized. There's also the additional cost of the upkeep, the maintenance, and the training of the staff. This also leads to downstream costs to the patient as the institution acquires these technologies. Increasing cost of delivery of healthcare increases, and ultimately this is borne about by the patient. Furthermore, the patient may be involved in the virtual reality platform, and that may require them to obtain their own personal devices and software, adding an additional cost individually. There is no doubt that virtual reality will be in some part of our practice. There is growing physician familiarity and confidence. Patients are very comfortable, as I mentioned before. Video games have become commonplace with virtual reality platforms being introduced into the household environment. There is both local and national availability of the technology. Unfortunately, there is some pushback from the insurance and payers. They are struggling with the additive value of this because there is additional costs to procedures that don't typically incur these costs, and they're trying to understand and balance out that additional value of technology with the incremental cost to the institution, the payer, and the patient itself. And lastly, we should not overestimate that there is no current, or underestimate, I should say, the current oversight or regulation. There may be varying regional policies in regards to its application in healthcare, and the challenge is standardizing this across all payers, platforms, regions, and nationalities. There is no doubt that virtual reality is here. It's currently being implemented in the household environment, as I mentioned, with video games. It's also being implemented potentially in the automobile industry and the aviation industry. There are a lot of synergies associated with virtual reality and the delivery of healthcare, both in the United States as well as internationally. Simplistic fashion in its utilization would be for training of residents and fellows, as well as young attending surgeons. And a more complex application would be intraoperative training, as well as patient education to improve outcomes, as well as to improve the overall satisfaction of the surgical experience. The biggest challenges will be payers understanding the additional cost and the value that would be added to the patient and the delivery of care, as well as the institutions acquiring this expensive technology. And then lastly, we have to struggle with the standardization of the differing virtual reality platforms as they become applied to different institutions, different geographic regions, nations, and countries. Regardless, I believe virtual reality will be here to stay, and it will become an essential component of our care in delivering the top-notch outcomes to spine surgical patients. I want to thank you for having me. Once again, it's a privilege and honor to be here today.
Thank you, Dr. Kansing. That was a wonderful presentation. I was reading a review where they said that the role of virtual reality-based simulators in some surgical subspecialties is standard, but in spine surgery, it is still a bit unclear. What do you have to say in this regard?
Well, I guess, let me clarify. So augmented and virtual reality are two separate things. Augmented is the addition, the overlay of images. Virtual reality is the recreation of the environment. Currently, virtual reality has no role in probably any operating room theater, but augmented reality does. Its incorporation. We were one of the first. I think we were the first institution in the world to use the Augmetics platform. It's still a work in progress. There's some surgical kind of ergonomic issues, workflow issues that are not still kind of intuitive to the surgeon. Looking through the lens, trying to overlook through the lens and look around the lens. The accuracy, the processing generation of the image and overlaying it, the real-time feedback, all that is still challenging. It's no different than navigation as it currently stands. It's a similar technology, so its accuracy is very similar to that. It's no different than a robot. In the robot that, once again, navigation based. So I think it's going to be incorporated. The question is cost and standardization. There's so many platforms, and when you have so many options and so many treatments, it means that none of them are really good. eventually a market leader will emerge. And I think once we have standardization, I think its incorporation to the operating room can be more efficient.
So when you said remote support for spine surgery, so would that be through virtual reality or augmented? What is the system that is used?
So I was actually, I participated in a preoperative evaluation with two surgeons in, I want to say somewhere in Europe. I want to say in Brussels. And we essentially walked through the imaging, walked through, and this was intraoperatively, and I could see the deformity of the patient. And this was through a augmented reality. So they were actually physically seeing, I could see the overlay with the glasses and everything else. And I could walk through kind of surgical procedures, walking through the steps. There's definitely a delay in kind of the real-time feedback. So it's not necessarily practical as far as actual live step-by-step application. But the fact is, I was actually seeing the surgery. I was seeing what was being done and then the overlaid images. So, I think as our broadband capabilities increase, as the standardization of the AR, VR increases, I think it'll be incorporated to collaborate with surgeons across the country, across the world.
So ASSI has started a capacity building program, and we have adopted one center in Gujarat, in Bhuj, and we have mentors in Ahmedabad, in Chennai, and in Mumbai. So because of the COVID, they could not visit there, but one of the industry partners are helping us getting virtual reality support. So would that be virtual reality or actually augmented reality?
Well, it sounds like it's training modules. So training modules typically are virtual reality. And if you look at the United States, the American Board of Surgeons, or American College of Surgeons, so that's the General Surgery Board, from when they take their recertification exam and their initial board certification examinations, they now train on an augmented reality module. So, I think we are probably a little bit behind some of the other surgical specialties, which have been heavily navigation or imaging based, ENT in particular, potentially even neurosurgery. So I think that training is going to be the easiest implementation because you can standardize the module, and that would be based via virtual reality. Surgical based collaboration, surgical based interaction would be more augmented reality.
There's a question from the panel. Will humans be taken over by machines and robots in the future?
You have to look at what we do. I think that the utilization of navigation and robotics for pedicle screw placement has been way overblown. That's its current iteration. That's the vast majority of the utilization of navigation and robotics currently. Until decompressions, until dural work or neural work becomes standard in place, that's another challenging. I have my own company that I'm working on for lateral-based access that uses ultrasound guidance that has a robotic application. So the robot docks the tube in the lateral position. So I think that the scope of the robot is actually increasing, but it's nowhere near close. I can tell you I will be retired before that happens. So I'm not worried.
Yes, doctor. Any other questions from the panel for Dr. Karan Singh?
Do you think, Dr. Karan Singh, that navigation and robots will be replaced by newer technologies in future where radiation would be eliminated by in the operating room?
Yeah, so I'm not sure if people are very familiar, but Google and Johnson & Johnson have a private collaboration. It's called Verb Surgical. I happen to help them out as a consultant. Google and Johnson & Johnson together can be a massively disruptive force in healthcare. If you really look at what Google is trying to do, and they're saying that the current medical device and technology implementation, the costs are way out of market. And so, yeah, I think robots will be more commonplace. They're developing a $20,000 robot, not a $500,000 robot. The cost of medical devices is based upon the ability to extract money from the healthcare systems, in particular the United States and somewhat of Europe. And that no longer is going to be present. So I think disruptive technologies as cost affordable pricing will enable adoption. And I think that as these other kind of traditional strategic companies get involved. We're talking about Amazon, we're talking about Walmart, we're talking about Google. They're all entering into healthcare. I think you will see disruptive technologies at cost-effective price points that will change how quickly we adopt technology. So I think that is coming.
Thank you.
Shankar, would you want to introduce the next speaker?
Next speaker is Dr. Suken Sa. We all know Dr. Suken Sa. He needs no introduction. I've met him several times in India as well, and he's a great friend of the Association of Spine Surgeons of India. He is always helpful to us, and he is one of the most prolific speakers in scoliosis surgery. But today he is going to talk to us about telemedicine to improve access to quality care and affordable spine care, as you spoke about capacity building, and it may be very relevant to our country. Welcome, Dr. Suken. And
thanks very much, Shankar, and thanks very much, Dr. Chabra and the organizing committee for this meeting. And just as we can't be with you in India for this meeting, telemedicine is just an extension of that same virtual technology that we've just been speaking about. You don't need to be present with your patient to still do an excellent examination and convey information. And that's what telemedicine should really be thinking about. And it took a pandemic for us to get here. We had concerns last spring. We didn't know what this virus is all about. We had patient safety concerns. We had provider safety concerns. How do we keep our employees safe, but still deliver quality medical care and mitigate the revenue loss that was happening when we closed clinics and closed operating rooms? The solution was telemedicine and digital health coming together to help everybody from a safety standpoint and delivery of care standpoint. And if you look at this data, we had already been doing a fair amount of telemedicine for a pediatric specialty care enterprise. But look what happened in March, April, as the pandemic crisis was raging on the eastern United States. We quickly pivoted to all telemedicine visits and skyrocketed the adoption of this technology to people who had never used it before. And then as we started opening the clinics again, you see the fall off. So clearly there's a role for this, and you see the sustained effort well above levels previously seen, where people are still doing telemedicine despite the fact that our clinics and operating room are wide open again. And I think a great example of why this works is looking back at value and how healthcare is delivered. Most of our healthcare actually occurs between visits. We're not with our patients every day, every week, every month. There's some preparation before the visit. You have the visit, it's a very short period of time, and then there's some work they have to do or we have to do after the visit. And then long swaths of time occur between the next visit, which is the same pattern. We have to disrupt that. We have to have continuous interactions with our patients, and preventative medical care can result in better outcomes. So this paradigm of care we're currently doing, where we have acute care hospitals, high complexity and cost, and very little patient participation, are going to shift into decreasing complexity and more patient and family-based participation, which they really want. They want the care where they work, play, and live, rather than travel long distances to tertiary care hospitals, which have very inefficient models of care. This is the least costly, the least complex, and provides the best patient satisfaction. So some things to consider for telemedicine are: what is the patient's experience? Are they going to feel like they just saw a doctor in real life? What hardware do you need? What software do you need? What practical workflow issues do you have? What are some innovative case scenarios? We can go over some of the things that we do here at Nemours. And how do you bill for it? How do you make it worth your time? And how do you provide quality care within regulatory issues? I understand that our regulatory situation in the United States or Europe and India are going to be vastly different. I'm going to speak very briefly about the regulatory environment in the United States, and you can choose your own situation for your country. What do you need as far as hardware? It can be very simple. It can be a phone, a laptop, or a tablet. But we also have these mobile workstations that we can use during clinic so that you don't have to disrupt your clinic workflow. I can come out of a patient room on Monday and still do a telehealth visit with someone who lives in Ohio, and then go back to seeing live patients. Or you can set aside a template of a half day a week where all you're doing that morning is telemedicine. And that really depends on what your workflow and preference is, whether you want to segregate it or whether you want to include it in your normal patient workflow, or at the end of your patient day, or at the beginning of your patient day. The software platforms are very diverse. There's a new software platform coming out every day. I think what you want to consider as the minimum bar for this is healthcare security. In the United States, that law is HIPAA, which provides for healthcare protection and personal information. You also want a platform that integrates with your electronic medical record. So as you're doing the visit, that case can be documented. As they come into the virtual platform, the electronic medical records show that they did appear for their appointment, and it also allows for ease of scheduling for follow-up or new patient visits. Now, during the pandemic, when a lot of these platforms didn't really exist to provide high output, we were using Zoom or FaceTime, which was a very unsecure connection, but still provided for a good patient experience. So that's available to you for those people who can't have access to this platform. What does your patient need? They literally just need a phone or some device for two-way video and audio communication. Again, they can go up to a tablet or a laptop as well, but then they need the actual software. This can be two ways. They can download an app or link to a service which would provide a secure VPN network or some secure connection. Sometimes, and as we've gone to, that app for telemedicine can be embedded into a larger app that they also use to view their patient records and schedule appointments. Again, a one-stop shop where they can use their phone, schedule the appointment, do the appointment, and receive information and instructions on what to do before the next appointment. Some practical tips, and I think for early adopters and people that don't have experience in this sort of environment, take this to heart, because these are things that we learned and are currently using. Involve your staff, your assistants, your trainees with the pre-work necessary to upload x-rays, MRIs, and CT scans. So you're not wasting time while you're with the patient to look around and search for these diagnostic tests. Have everything uploaded beforehand. Prepare for that visit just as you were prepared to go into the patient room where you already have an understanding of perhaps the diagnostics. Over-communicate with that patient to ensure a good experience. No one likes the stress of having a poor connection or having a disruptive connection during an actual meeting. Prepare the patient the same way and use your staff to do that. Ensure proper tech support. Maybe even do a rehearsal with your staff. Do they have that link? Have they downloaded the app? Are they ready for the visit? And then how are you alerted that they are in fact ready for that visit and in that patient room, so then you can go into that room? And then again, we spoke about this earlier. How do you want to integrate this into your workflow? Segregated on Friday afternoons or sprinkled through your normal template on Monday and Thursday and going in and out of that? And then how do patients know that you're doing it? Spread the word. And if they can't hear by their other patients and word of mouth, social media is the new paradigm for word of mouth, and make it known that you're seeing patients virtually and they will come. Some people after the pandemic have switched their practice entirely to telemedicine in areas such as dermatology and psychiatry. They can work from home and they can do this very effectively and very efficiently. I think for orthopedic surgeons and spine surgeons specifically, what type of patients can you see with telemedicine? Obviously, you can't see everybody. The ideal patients to start are post-operative follow-up. They know you know them, you know what you're checking for, and the visit can be done very effectively in 2 to 5 minutes. Now, granted, if they needed x-rays, they may have to get the x-rays outside, upload them to your site, and you can review them. Simple follow-up. How are they doing after physical therapy? How are they doing after the injection? How are they doing after bracing? Patients you know, again, and who know you, will be very familiar with you when you appear on the video screen. Quick checks of the incision, comfort, range of motion, do you need another refill of your prescription, are well done through telemedicine. And at least in the United States, the global period after surgery, we don't get paid for 90 days. And so this is a very effective use of our time without receiving additional revenue. What about if they're a known patient and they went to get an x-ray or they had an MRI, you just want to review the findings and schedule surgery? Again, an excellent use of telemedicine. Review the findings, show them what you see on the MRI, and then they understand that they might need surgery. A surgical discussion becomes a next level of complexity. Again, if you've never met the patient, but you're seen as an expert in the field, they don't have to travel to see you. This can be a good use of their time. avoid expensive travel and that face-to-face interaction and get the answer they need, and then they can see you for a pre-op consultation later. New patients, and this comes into that second umbrella, once you're facile with this, move on to new patients that you can see. And this is what Dr. Chabra asked me to talk about. How can we use telemedicine to increase access and improve care? It's really expanding that patient base. So go to outreach clinics. Don't leave your home in Mumbai or Delhi. You can go to central India virtually and expand your reach and improve access to patients who cannot travel but who still need your care. Virtually triage and pre-screen those new patients before they make the trip to the large cities and expensive hospitals. Help them understand that they can stay in their local environment, or they do need that tertiary or quaternary care and have to travel. Perhaps you can see an entire family with one telemedicine visit and explain to the caretakers that when your mother comes home, they will need this, this, and this. And the pre-op consultation before they travel, again, is very important. What about emergencies? A traumatic car accident, 4 injured victims. Maybe this one needs to come to the central hospital and the other 3 can be triaged to local environments. And it can really streamline that emergency transfer. Rather than have them go to 3 hospitals, have them go to the hospital of their destination the first time with the first transfer. What about specialist to specialist consultations? Perhaps a deformity surgeon can speak to a general spine surgeon, or minimally invasive surgeon can speak to a general spine surgeon. Help them understand how these techniques might be used in their practice for this patient. And those are called e-consultations between provider and provider. And certainly patients can seek second opinions virtually without having to travel, even from India to the United States. This virtual triage or pre-screen can be very effective to save time. So here we have a patient with a problem. You can use telemedicine to talk to your nurse or assistant, get the basic history, demographics, what type of insurance, and where are you located. And then they can say, okay, you don't need to see the spine surgeon, you need to see your physiatrist or rehab or pain medicine doctor. Or you don't need to see the spine surgeon, you need to see our bracing specialist for your mild or moderate scoliosis. This increases satisfaction and decreases expense and avoids the error of going to the wrong doctor the first time. You can involve multiple family members who live in different locations. If they're children in the United States and the parents are in India, you can involve them into the care rather than taking phone calls in the middle of the night, because not everyone is integrated into the same care plan. And again, these second opinions can become very effective for patients to seek the provider who's an expert in that very rare condition and get convenient access to that specialist. I think we should spend a minute on how to examine patients virtually. Do you have the studies uploaded? We spoke about that before. Is the patient prepared for the exam, or are they dressed in a suit and tie? No, they have to be dressed just like they would be in the examination room. Do they have a gown? That's okay. Use a bathrobe or some kurta or something like that that can cover themselves but still examine their back or neck or feet for a neurological examination. So for girls, we prefer sports bra or bathing suit. For boys, just simple shorts. The exam is likely to require somebody's assistance. Maybe they need to hold the camera while you examine the patient, or vice versa. So have them help out, and they need good lighting. Just as you need to see the patient with good lighting in the office, they need good lighting at home so you can examine them virtually neurologically, see skin lesions, see the contour of their back, see the incision, and so forth. I think I'm going to go very quickly through telemedicine compliance and billing. In the United States, we have Medicare, which really dictates the healthcare laws. Where is the care being provided? Where is the care being delivered? Is it live face-to-face? That's called synchronous. Or is it asynchronous? I reviewed the studies last night, and I'm going to email you or send you a recording of what I think you need done. That's called asynchronous. Typically, Medicare didn't pay when the patient was at home. Now that's changed. Typically, Medicare doesn't pay if you have these other sites. You really need to be in the physician practitioner office or in a hospital environment to deliver that care. And really right now, only physicians or nurse practitioners can deliver that care. But maybe in the future, you can have other medical care providers that can deliver that care. There's a lot of difference in where there are insurance companies are paying 100% of this visit or decreasing reimbursement. Check with your payer about how this is going to work out for you. And if you're billing for cash, then you can make that arrangement with your patient as is. So there's a lot of cost shifting and laws to keep in mind. So study the laws in your local environment and make sure you're doing this properly or you will not get paid. Now, in the COVID health emergency, we had payment for all areas of the country. I don't have a license to practice in Illinois, but I could practice in Illinois during that emergency visit. We were getting reimbursed the same for in-person. Is this here to stay? I don't think so. I think the laws are going to change a little bit in favor of telemedicine before the pandemic, but not as good as it was during that emergency. So I think I'll summarize now that telemedicine is a definite tool that you should incorporate into your practice. It's not for every patient or provider, but has tremendous power to increase access, which for India is so critical to expanding specialty care to the rural environments. Expand your patient base to neighboring countries even perhaps, and provide expert evidence to those doctors who are not trained as well as you are to provide similar quality of care with your help. Check your local country information for reimbursement and healthcare laws and licensing. You have to be flexible and patient when you first adopt this technology, but it's been an ideal way to handle the COVID-19 pandemic without exposing your staff or your patients to an environment that they feel uncomfortable with. And it's a great way to reimagine how we can deliver healthcare in the future. Thank you.
Thank you, Dr. Sukensha. That was a wonderful talk. We have now telemedicine guidelines in India. And as per that, if you do a video consultation, vis-a-vis if you do email or a telephonic consultation, there you can prescribe only certain drugs per se. So you can't do a overall prescription unless you have a video consultation, and there too there are drugs that you can prescribe. What are the liability rules like there in US? In India, they are liable as an in-person consultation. So is that a limitation? The other question that I have is, how do you overcome the limitation of not being able to perform a hands-on examination in these patients?
Yeah, great questions. I think right now our biggest limitations are licensing. So after the emergency crisis was resolved, we went back to, in the United States, I can only practice in states where I have a medical license to practice. That protects me from a liability standpoint and also allows for billing. Now, if I choose not to bill, I can provide medical evidence to a limited fashion to anybody. We used to do that with phone calls all the time. And that's up to your provider. If you feel comfortable providing medical advice without billing for it, you cannot be called into court or you cannot be accused of practicing without a license. But when I try to bill for that, I could be. So right now, the limitations are legal. We don't have any limitations on who we can prescribe drugs to or physical therapy or provide advice except for that legal limitation right there. And then the physical examination is really one of the provider to patient issues that we have trouble with the most. I provided you some advice on how to do that virtually, but that's why this right now is just going to be focused to simple problems or patients that you know. Or, okay, now I understand you have a severe spinal deformity. Let's take the next step for you to travel to Delaware and have your care here. And that's what you can use this for. You can use this to triage the patients in the rural areas to need to come to the cities for specialty care. But in the future, and in some aspects, we still have this. The cardiologists and transplant surgeons do this very well. They have limited modalities where they can do pulse oximetry and EKG and heart ultrasounds and measure body fat and measure some other issues like labs with a finger stick. They can walk into a pod, have all these tests done, and then do the telemedicine visit later. That's really amazing. And that's going to be difficult for orthopedics because we do a lot of manual measurements and range of motion and side-to-side bending and do this. But we're only limited by our creativity and the innovation in technology right now.
I believe you can do knee examination now by sensors, and that's how in UK, the British Orthopedic Association post-operative knee replacement consultations are totally by telemedicine, right?
Yeah.
I was going through, and in Australia, they started a telemedicine network, referral network for pediatric cardiology in 2000. And they have a very well-established pediatric referral network across Australia. So it helps in access becomes easier and people don't need to travel. So any burning questions? We are running a bit late. Any burning questions to Dr.
One question, Chabra, I have to Suken and to you as well. One quick question is, when we do a telemedicine call on the telephone, the patient on the other side can record your call. And what is the legal liability of that? And when he replays that call with another third opinion or fourth opinion, and sometimes I see in WhatsApp messages that the court has said that WhatsApp messages are liable to be actual legal evidence, and then you can do. So we do a lot of telemedicines on charity, on just good Samaritan, or sometimes on payment. And so there is a lot of confusion at the moment. So would you, since you have a lot of knowledge on the advocacy and things in the legal aspect, would you throw some light for all the audience? And
Yep. Suken, go ahead.
Yeah, I think, obviously I'm not an attorney, but you need to know your country's laws. We in the United States are protected when we do charity work and Good Samaritan work from being sued. Many of us also work in healthcare systems where the institution stands behind us from a legal standpoint. But if you're off on your own and practicing in an environment not supported by your institution, I would be very careful to provide medical advice, especially in very complex problems. As far as phone call recordings and so forth, unless you were notified that this phone call is being recorded, that evidence cannot be used in court, at least in the United States.
Shankar, I will let you know about the Indian telemedicine guidelines which were implemented last year. And as per that, in fact, you need to record all video consultations that you do. It is mandatory.
Ourselves.
You need to record them and you need to keep them. And your liability is as much as an in-person consultation. So that is as per the telemedicine guidelines. So we need to be careful when we do this. We need to be aware about all the guidelines that are prevalent. So
Can I ask a question to Suken?
Yeah, sure, Samajit, a quick question.
Hi, Suken. Great talk. So I was doing quite a bit of telemedicine during the peak of the pandemic in our country. Now the pandemic is receding. And I do find that a lot of patients are refusing telemedicine in spite of the fact that they're 500 kilometers away from my place. So they want to come in more rather than get into telemedicine. So are you facing the same, or is it the same before the pandemic?
No, I would agree with you completely. You saw that graph I showed you. That's real data, that fall off. And as soon as we opened, yes, they did want to come back, but that's okay. The ones that want to come back, you see in your clinic. The ones that don't want to come back or can't come or want to see whether they should come, that's where this technology is most useful. It's expanding access. Don't worry about the patients that are already coming to you. This is a way to see more patients that can't come to you.
So it is much better if they could not, because the postoperative follow-ups and the long-term follow-ups do not really need to come in. They can get an X-ray locally and get to transfer that X-ray to us, and they can just speak on a video, but they just refuse to do so. So what I mean to say is that the comfort level of seeing a doctor by a patient is much more than whatever telemedicine can reach.
I agree, but think about it from their perspective, just as our perspective. Our comfort with telemedicine is improving. Their comfort with telemedicine will improve also. Yep. We didn't like to talk on the phone before. We didn't like to do Zoom calls before because we were in person. Now we have to, and it's worked out well.
I'm sure it will take time for the people also to get used to telemedicine, as Suken said. So we thank Suken, Dr. Khan Singh, Alok Sharan, and Andrea Luca. It was a wonderful session here, and we'll look forward to having you again for our next conference and next events as well. Thank you. Shankar, would you want to introduce the next speaker?
I think and the next speaker is, we have heard Dr. Sami before on the future of robotics in spine care. This is another exciting field which we know very little about. And I welcome, he's ready with his talk, and I welcome him to give his lecture.
Yeah, thank you very much, Dr. Shankar, for the introduction, and thank you to ASSI for having me here today. So it's a great pleasure, and I already was able to listen to some very interesting talks, and yeah, I will use my time hopefully wisely to kind of give you a little bit of overview on the future of robotics in spine care in the next 10 minutes and for the foreseeable discussion. And I'm looking forward to the questions in this context. And I'll try to kind of reach a little bit further away so that kind of also the potential applications that are maybe not yet established in the field become at least parts of our thoughts. So it's always a great pleasure for me to talk in front of medical doctors, because obviously this bridge is very important, especially for us technologists. I was hearing a lot about discussions on robots and AI possibly taking over. So I think it's very important that there is a tight bridge to kind of come to this future of AI and robotics really supporting us in the daily care, daily medical treatment, and really as a kind of a service, as a tool to the medical staff, in a sense that it really kind of relieves from burdens and gives new abilities. And I think this is very interesting, especially with the recent rise in robotics and in particular also AI, so perception and making use of data, and then obviously kind of closing the sense plan act loop as a potential tool for various applications. I think it's very well known, obviously, in this esteemed circle that the surgical robotics development has tremendously progressed over the recent years. It kind of, in a way, started with the Da Vinci system really becoming the state of the art in various kind of application domains, in particular in urology, and then also later on going to surgery, cardiothoracic, and so on. So what is kind of interesting is this idea of giving a doctor a tool that is able to kind of operate remotely via kind of a pretty big robotic system, but with very cleverly designed end effector tools, and then giving the impression of an avatar, one could say. So bringing the skills of the doctor to a remote location that he is not physically at. So very related to the talk we saw before in terms of telemedicine, one could say, but with physical remote possibilities on site, in this particular example, in the body. And obviously surgical robotics have also entered neurosurgery with various procedures in DBS and SEEK. And in particular, these so-called position-controlled devices were so far mainly used for navigation tasks, for so-called position-controlled operations. So no feedback of the haptic sense of touch to the surgeon so far. But over the last years, various hundreds of thousands of patients being treated in various applications ranging up to radiosurgery. So what is kind of interesting is in particular the idea that not only the robot, the physical object, but also the registration and the sensory setup on site are supposed to support, for example, I heard something about the pedicle placement, I think 2 or 3 talks before, where in particular the robot is essentially kind of a flexible tool that you can position in order to support you with a kind of a very strict positioning constraint, so that the surgeon is really empowered to kind of use his dexterity, his sensitivity, but the nice navigation properties and stiffness of the system to really place the particular objects in the body. And these kind of systems have become kind of reasonable and standard. However, they are in some form dependent compared to industrial robotics for the classical industrial robotics in car manufacturing. So very strong position control devices, not yet tactile sensation. So the interaction with the physical body is still limited and not yet displayed to the surgeon. In particular, another kind of rather recent direction in surgical robotics is what happens if we come into curved and particularly unreachable situations. Then obviously we need to think about fundamentally new ways of designing robots. So the mechanical systems, so one could say the body of the artificial intelligence of that kind, that is able to kind of sneak around the cavitations in the human body and really be able to explore in a way, in a safe, however dexterous way, and obviously into the smallest ways possible. So these so-called continuum robots are in some form, one could say, the next generation of endoscopy snake-like systems that are typically controlled via what we call bioinspired control systems. So the idea is to have remote actuation, which makes it possible to really have very small and delicate structures exploring the human body and giving a kind of a new way of really having a continuous or continuum avatar in the system, in the human body for the doctor. Various systems have been designed up to the smallest scale, so really orders of magnitude smaller than typical surgical robotic systems. We heard also about the Verb Surgical as the kind of unification of Google and Johnson & Johnson that try to kind of make surgical robotics available and affordable. I think it's very clear that the miniaturization and the kind of new way of designing robots in a much more balanced way that are compatible to the human body seems to be the very direct next extension, and giving robots a new way to explore not only the human body, but also place novel types of sensation and giving feedback to the surgeon at hand. So very different applications can be thought of. Here we can see in a form that the end effector has some functionality. So in this particular example, it's an optic catheter with a directional fiber, so we can essentially have control thermal energy at the particular site where we want to implement it. So it's not always about getting feedback, but also about getting the treatment there. And then obviously you could also apply MR thermal imaging with this novel kinds of ideas like LIT, laser interstitial thermal therapy, which we see here. And then obviously over the next years to come, there has been new prototypes that kind of bring also two hands into the body. So not only various robots coming from different sides, but actually having kind of multi-port systems that are able to really give a miniaturized representation of the surgeon into the body and give them the feedback to the system. And there's this kind of evolving further and further into the field of what we call nanorobots, medical nanorobots, where small capsules can be basically brought through the body, typically at the moment still externally controlled via electrical or magnetoelectrical fields, and however thought to be self-propelled over the course of action. So with these kind of thoughts, it's very clear that with the next generation of robots, in particular with an artificial sense of touch, we can think about new types of systems that do not only give you visual feedback or are able to steer around the body, but in particular with an artificial sense of touch that is typically being realized by what we call strain gauges or optical technology to then display the forces that are felt in the body, plus certain model-based control and AI algorithms, to then have robots that can be taken by the hand that really have a sense of touch, that are able to essentially render human interaction, human safety, and in particular the human neuromotor control system to then be able to be safely interacting with potentially fragile objects with the sense of touch, and really being therefore also a tactile feedback system if you want to use it for similar applications we see with the classical surgical systems. So with these systems, regardless of the environment, whether it's spongy, whether it's very rigid, the robots are able to show and render very high performance force rendering. So the tactile sense of touch is in fact much more kind of reliable and repetitive compared to human sense of touch, obviously. So higher quality and higher monitoring of the particular operation could be done in principle. Still, however, mainly in the lab and not yet have reached the operation room. Another important aspect, if we think about the future of robotics, is how do the human models, the kind of not the static visualizations, but really the human models into the kind of thought of the robot, how can they make use of this? So the human visualization obviously has made tremendous progress over the last 3 years, coming up to the kinematic renderings where we can really see almost at kind of visual video level really into the human body. However, this is not yet the functionality, so the functionality has to be coupled with the robot, and for this we need to understand in a real-time fashion, giving external sensing, how does the internal neuromechanics or other internal body functions interact, how do they kind of change over time, the internal functionalities, the forces, the chemical process and so on have to be rendered in real time in order to then be able to use to understand not only the control principles of the human internal, to then design systems that can be compatible with that, but really be able to also kind of understand in some form the programming of the human neuromotor control system, for example, to then bring that kind of understanding of the human dynamics, kinematics, but in particular control principles such that they can be used to program essentially virtual humans, one could say, to not only do motions, but to actually produce the forces, the interactions that really are necessary to drive the human body in a sense. So it could be kind of the motors of the human body really being well understood, and then make out of the body a robot that basically can be programmed to then finally not only have this for the upper body, but also for the legs, and then really make intelligent exoskeletons, for example, that then can make use of this kind of neuromechanical models of the human to make model-based control, to give assist as needed in various applications, and really with this understanding of the human body, make the robot understand what the right treatment in an adaptive and kind of intelligent fashion could be, to then really be of a better assistant to the particular human need. Obviously, there's many applications in this direction. The last one I just want to point towards is so-called brain-machine interfacing, which I think it's very clear, especially with the recent kind of announcement from Neuralink of Elon Musk that you might have seen, where the idea is to not only interface the human brain, the spine, or other kind of parts of the neural system, but then also use these neuromechanical models and the understanding of the human body to then be able to control complex robotic or assistive devices with the understanding of the human, not only brain, but also with the motion mechanics and the neuromechanics, then be able to connect brain-machine interfacing with robotic devices, and then be able, this is a very famous video kind of almost 10 years ago, which we did together with John Donoghue at Brown University, which was the first continuously controlled robot arm. And the lady we see here in the image was able to control just with up to 10 neurons that were directly interfaced a 19 degrees of freedom robot system just by thought and in a continuous fashion. So really, she thought in some sense this is her arm. These experiments are currently for the next years are being recreated again in our labs and obviously on larger scale. But the idea was really to fuse robotics, AI perception, plus the understanding of the human body to really bridge the gap between these kind of the embodiment of the human itself, the robot as the potential avatar of the human, obviously in the context of neural control, telemedicine, and rehabilitation. This is kind of the key technology that really might be a game changer in that respect. So I would like to thank not only ASI for having invited me, but also would like to take the chance to thank all the generous support that we received over the years for our funding. And yeah, thanks a lot for your attention, and I'm looking forward to the discussions and questions. Thanks.
Thanks, Dr. Sami, for this mind-boggling presentation. I think what you spoke in 10 minutes would take us at least one day to basically understand what you're talking. It's so much of information and so much of knowledge at the moment. So I would welcome questions, because I believe there will be a lot of questions. So we are a little short of time. Questions from the audience? I think all are spellbound.
Dr. Sami, you had mentioned about the application of robots, but they are more towards neurosurgery. When it comes to the spine, when do you think will we have a proper application in the cervical spine? It will take time because you are not able to control the movement there. And right now, the robots available are not approved for use in cervical spine.
Well, I think there is a fundamental technology gap that we are still facing in a way. So thanks for this question. Because I think it's very clear that we need very flexible and dexterous systems. So this idea of continuum robotics that I was showing, I guess there is still a lot of development that has to be done there. And then there is also the important aspect about online navigation. So in order to really have robots being able to be as dexterous and flexible in the cervical spine, I think it's very important that the registration and the online navigation, similar almost like an autonomous car, one could argue, have to tightly integrate with each other to really be of a very precise and also dexterous system at hand. So I think this will still take several years to get to that level that it really becomes clinically widely used. So there are still very basic questions to be asked. In comparison, one must admit to the rather classical way of surgical robots. Yeah, indeed.
Bhavuk informs us that the Globus Robo is approved for cervical use as well, but I'm not sure if Bhavuk has used it in the cervical spine, because even say when you use it in the thoracolumbar spine, because with the slightest of movement, the registration may get affected, and you may not have the precision per se.
It's
to be honest,
it's actually the cervical instrumentation is quite different, and they have different instruments for this. We are just in the process of purchasing that. Dr. Sajan Hegde, as far as I know, probably he has those cervical instruments.
Sajan would like to comment? No.
I'm not sure if he's there. Sami, you were saying something?
Well, I think I just wanted to support what you were saying. I mean, of course, it's always possible to kind of design very specific applications. But if we think about what you just said about the registration process, in order to get to intelligent robots, and not only, I mean, a robot, if it's just a tool in a way that is barely a kind of a positioning device, then it's still at the bridge between being a pure machine or a mirror machine and an actual robot that really has a certain level of autonomy. So I think this is kind of the question also on the definition level. So I think it's as always, the more flexibility you want, the more advanced, but also the safer the technology needs to be. So, and I really think that this combination of imaging, model-based complementation of kind of human models and the tight interaction with the robot are really vital, because we have seen over the last 20, 30 years in various applications that these kind of limitations have already been creating various problems also in spine surgery, right? In all the clinical applications we see so far.
Dr. Drazen wanted to make a point on robotic use. Please go ahead, Dr. Drazen. Dr. Daniel Drazen, you wanted to make a point? Yeah.
Yeah, sorry about that. I'm still starting my video. I would just say that in the cervical spine, yeah, the Globus robot is used regularly. For Mazor, it is off-label currently just because of the mobility in the cervical spine. They are working on trying to get that sort of proven as an exemption. And so I think that's sort of a futuristic possibility.
But you have, it is being used in the cervical spine with precision and, right.
Yeah, I've used it for the Globus, mostly for like C7 pedicle screws and a C2 screw, but you know, most of that stuff I just use freehand, but I have used the Globus robot for the cervical spine. Haven't had any issues. I've had issues in the thoracic spine with that robot a few times.
And no issues with deformity use where the anatomy gets changed and you have, for example, in a kyphotic deformity, registration sometimes becomes a challenge.
Yes, exactly. The registration becomes a problem mostly for the obese patients and patients who have severe deformity. And those are the patients that you have to decide whether to continue using the robot or to kick it out, which I've done on occasion.
So thanks, thanks, Sami, joining us. And we heard you also during Spine 20. And I thought we can have the ASSI members listen to your mind-boggling talk. Thanks, and we'll look forward to long-term collaboration and having you again and again. With that, we will move forward to Dr. Daniel Drazen. He'll talk on potential of big data, computer vision, artificial intelligence, and machine learning in spine care.
I'm Dr. Daniel Drazen, and it's my honor to be speaking to the Association of Spine Surgeons of India. Here's my disclosure. Of note, I have greater than 35 papers using national databases. Robots and artificial intelligence are here. In parts of the world today, they are scanning people's temperature as part of pandemic testing. The future of spine care will utilize artificial intelligence and robotics to reduce costs through accurately predicting who will benefit from interventions and support spine surgeons in performing a safe and human error-free surgery. You can envision a time where a patient comes in with back pain and their medical chart, guided by AI, helps tailor the specific treatment pathway that minimizes the risk of complication and maximizes their outcomes. We are currently in the midst of a data explosion, unlike any other time period in human history. Continually increasing computational power, advancements in analytical methods, and widespread interests are driving technology forward at an incredible pace. At the crux of this is our ability to leverage powerful tools to learn from and act on the massive availability of digital data. Big data is characterized by 5 V's: volume, velocity, variety, veracity, and value. Due to the challenges of volume, velocity, and variety, many healthcare organizations simply ignore or discard potentially informative data. If we think of organizations as creatures, most healthcare systems are at the primitive level of life. Their IT systems are not up to the task. Perhaps the biggest benefit of big data in healthcare is the possibility to obtain individual treatment effect. Randomized clinical trials produce average treatment effects. However, individual responses depart sometimes widely from the average treatment effect. Isn't it important for any treatment to know who benefits, who doesn't, who is harmed? We want the right treatment for the right patient at the right time. The right treatment involves discovering an individual patient treatment effect, the essence of precision medicine. Randomized control trials have restrictive inclusion-exclusion criteria, optimizing homogeneity. This restricts some patients eligible for the treatment. Real-world data is needed. In the medical field, there are a lot of big data sources: claims, databases, databanks, electronic medical records. And interpretation of databases is difficult without data on indications, specific procedural details, comorbidities, and patient-reported outcomes. The major concern with these databases is a lack of granularity and the high likelihood of errors in coding. Here's an example. An article was published in JAMA in 2010 on trends, major medical complication, and charges associated with surgery for lumbar spinal stenosis, used a Medicare Part A claims database from 2002 to 2007. They looked at 3 categories of intervention: decompression, simple fusion 1 or 2 levels, and complex fusion greater than 2 levels. ICD codes identifying the number of levels fused were not available until October 2003. So a multi-level single approach surgery in 2002 to 2003 would have been coded as simple. Now, these same surgeries were considered complex in 2003 to 2004. So if you look at this figure, there was a majority of increase in reported complex surgery that occurred between 2002 and 2004, with only a minimal increase between 2004 and 2007. This change in coding methodology could account for a substantial proportion of the increase in complex fusion. The limitations of this data was delineated in the discussion. I highlight a few of them on the slide. Diagnosis and procedures may be miscoded. The level of detail in ICD-9 spine surgery codes is limited. Appropriately, Dan Resnick responded to this article and said, "Overinterpretation of such data is potentially misleading." Now, some of these issues have largely been addressed by ICD-10, but we are still using databases from ICD-9 coded patients. To address the lack of granularity, registries were developed in spine surgery. In the US, the QOD and the American Spine Registry are the most robust. There are many international registries as well. Challenges with data quality and collection are reduced with a shared data collection platform. Big data analytics is a shift from traditional statistics. Statistical modeling is designed for inference about the relationships between variables, while machine learning is designed to make the most accurate prediction. Predictive models using machine learning techniques enable surgeons to anticipate everything from the best course of care to operative complications. The complexity of these tasks render them poor candidates for traditional statistical methods and more promising candidates for machine learning. Indeed, studies have shown that statistical predictive models of complications in spine surgery often perform poorly on external validation, indicating that the corresponding results are representative only of a specific cohort and cannot be generalized to the patient population. Analytically, individual treatment effects are obtained from predictive modeling. Patterns are learned from large amounts of data, and for an individual, based on the characteristics, predictions can be made. This is what is known as machine learning. A graph of the machine learning process is depicted from the learning phase to the prediction phase, and a more complex one on the right. The most used machine learning model in spine surgery is supervised learning. For example, a database of lateral x-rays has films pre-labeled as either fracture or no fracture. A portion of this data, the training dataset, is analyzed to build a model that synthesizes the pattern between independent variables, example, a pixel in an image, and dependent variables, the presence or absence of a fracture. Individual radiograph pixels in this example are known as vectors. The remainder of the X-ray films, the untrained dataset, are fed to the machine, which is then assessed based on its ability to accurately predict a fracture. Accuracy of these algorithms are often reported as area under the curve, or specificity percentages. Now, this was very timely. An article on machine learning was published this week in JAMA Surgery, and it's a randomized clinical trial of 683 surgical patients undergoing colorectal and gynecologic surgery. The primary outcome measure was accurate prediction of the duration of each scheduled surgery. And the implementation of a machine learning model significantly improved case duration accuracy, reduced patient wait time, effected no change in time between cases, i.e. turnover time, and reduced the use of pre-surgical resources. We are seeing an increasing attention toward machine learning in spine surgery. In 2018, there were less than 40 articles, while in 2021, there's greater than 160. Machine learning has been used to predict patients most suited for outpatient surgery, identify risk factors for complications such as readmissions or adverse events, or predict preoperatively the length of stay following different types of fusions. A lot of these studies, I have to mention, are conducted retroactively using national data sets. There's an interesting article out of Harvard that was using computer vision to identify the manufacturer and model of anterior cervical spinal hardware. Now, not all predictive models work. For example, we identified a cohort of 30 validated predictive models of complications following spine surgery, including degenerative conditions, deformity, infection, and trauma. And we found that models in the deformity subset that included radiographic and anatomical grading features reported higher areas under the curve values than those that included only patient demographics or medical comorbidities. In an analysis of 59,000 patients, this article looked at patients undergoing spinal fusion, and they used multiple machine learning algorithms to reliably predict the risk of a discharge to other than home. And yet another article looked at radiographic automated machine learning algorithm for detecting vertebral compression fractures. They had a sensitivity for 95.7%. Surgical robotics and computer-assisted navigation are especially well suited to AI. Image processing is a key strength of AI programs, and navigation stands to particularly benefit from evolving AI techniques. Furthermore, AI can facilitate surgical planning to each patient. By accounting for anatomical variations among patients, the image processing prowess of AI allows exact reconstruction of relevant spinal anatomy during surgical planning. And in addition to navigation, surgical robotics have the potential to transform the field of spine surgery by increasing precision, thereby lowering complications from human error and inefficiency. I've published on databases for years, and I am very excited that machine learning algorithms will help lead precision medicine into the future. By catering outcomes analysis to a specific patient, We have the power to supplement years of clinical experience and knowledge with robust mathematical estimates, augmenting our ability to counsel patients and focus more closely on the individual needs of patients. Robotics are helpful and are here to stay, not replace us. The technology will continue to evolve, and it's important that we surgeons remain in the driver's seat. Before I close, I want to highlight my course in Seattle that is in its 6th year on robotics, endoscopy, emerging technologies, and navigation. It will be a hybrid virtual and in-person course. I hope to see you there or online. Thank you very much.
Thank you, Dr. Daniel. And that was an excellent talk. And I think we don't have big data in India, so I would be happy to take some questions from the audience. And we look for a way forward because, as you said, your ICD-10 coding is quite standardized in the US. We don't have a very good standardized coding system as yet for surgical documentation. And we are just new in making our spine registry. And so at the moment, may I ask Bharat to comment on the challenges we face in the big data collection?
Dr. Daniel, my question is, how do you track the follow-ups? Do you have a special system where the patient follow-up is taken because the registry needs follow-up?
No. So, for example, the large databases track patients. So, for example, we've published on patient data for tracking patients for 5 years. So, in the national data sets, there is that. In terms of the spine registries, one thing they do is they ask for follow-up for the patients. It's very attainable to create a spine registry among like a multi-center group of surgeons to say, okay, we're going to just, the biggest impediment is the creating the form and getting permissions, but it's totally possible to track a patient. Obviously, the biggest issue is a patient goes to a hospital outside of any of the hospitals that the data is included, and those are the difficult ones. But for a lot of our studies, we were able to track patients for greater than 5 years in the national data sets.
Yeah, and is it a challenge to have the data confidential? How do you manage that?
In the registries, it's not complicated because the way it's entered is it's all confidential. But it took a while for them to set that up. In terms of the national data sets, those are all de-identified. So those are all paid. A lot of those are paid databases. So the money was put up front. Mm-hmm.
So there are questions in the chat box.
Yeah, the question is from Dr. Tarush to Dr. Daniel. He says, machine learning to assess patient outcomes would be reliable within a country or a region within a country. For a large country, how much can it be extrapolated for the world? How much time do you think it would be before we have reliable machine learning, say in the US, as we say in the US?
Yeah, so that's definitely an issue. The practice patterns just across the United States are very different. The types of surgeries that are done, I live in Seattle, types of surgeries that are done within 20 miles is very different. So that's one thing that's helpful, I think, when we're looking at national data sets, is the regional variations. So it definitely can't be extrapolated. There's no one answer for one problem for one patient. And that's what I think machine learning helps, is to sort of take all that data together and put it in and see how you could learn from what other colleagues are doing. For example, some people are maybe getting away with anterior-only approaches for some sorts of degenerative disc disease and not relying on doing anterior-posterior, and they have very good outcomes. And so, minimally invasive techniques, for example, is also a great one to look at. Again, the biggest issue is the continuity of patient-reported outcomes. The issue with a lot of database research and a lot of papers that get rejected by us is because there is a lack of granularity and you don't have that data on outcomes. So that's why the benefit of registries, where it includes patient-reported outcomes, is really helpful. I see, a bunch of people here who've also published on registries, so that they could also chime in. I know Neil Anand's he's published on that as well. So, you know, it's a complex issue that we are continuing to work for. We're definitely not through it. It's sort of the beginning age of it. There's still a lot of data and a lot of time that needs to be spent on clearing this up.
One advice I want from you is, for a country which has poor resource allocation and fund allocation like India, how much resource allocation or manpower allocation do you think is required for registry and large big data collection for a
Right. So
healthcare service?
yeah, it's a good question. I mean, I think the biggest issue, as I mentioned, is the IT infrastructure, creating a platform that across disciplines that could work out for everyone, and that is the biggest impediment, especially with say, you know, primitive infrastructure that may not be similar to electronic health records. So that's the hardest part. And I think as surgeons, you sort of have to be the leaders and push forward as best you can. And how do you do that without funding? You know, is there some outside, you know, organization, or like, you know, Dr. Singh mentioned Verve, where you have a Google and Johnson Johnson. Is there some sort of, you know, outside industry that could help lead you forward? Because that would be helpful in terms of regional variations in your country.
Thank you very much.
Do you have, Daniel, you know, the person who enters the data, do you really train them, or do you have some courses where, you know, you have the person who enters the data is trained?
Well, so there's different sides of that. What we found is when you have people who aren't spine surgeons entering the data, there's a lot of issues because that's where the miscoding happens. So what happens with the registries, it ends up being either the surgeon or a resident or a fellow that ends up entering a lot of the data, or a trained coordinator. As you know, the issues with coding, as I mentioned, is such a complexity that you really want someone who really understands the patient characteristics to enter the data. You know, is there a future idea that the patient enters their own data? Possibly. That could be a solution.
Thank you very much, Dr. Daniel. We are running a little late. If there are any burning questions, I'm sure Dr. Daniel will be available on the chat box to answer those questions. We move on to the next talk and invite Dr. Larry Lenke, who is going to talk about 3D printing in spine care. Before he starts, let me tell you, Dr. Lenke, that we tremendously enjoyed your interview. Everybody had a great time, and I think it was tremendously appreciated. We'll ask you the questions for your interview. Since you escaped that part, we are not going to leave you. We are going to ask you some questions at the end of this session.
Hello. I'm Larry Lemke, and I will be discussing the role of 3D printing in spine care. Here are my disclosures. 3D printed models are created from fine cut CT scans. We find that the 3D printer quality equates to the 3D model quality that's produced. Pre-op, we use these for pathoanatomic study of the spinal column, intra-op as a navigation tool, and also as a vertebral pathoanatomic view and guide. And post-op, we either save the models or give them to the patient as a souvenir following their spinal reconstruction. Here is a current view out my office window showing the hundreds of 3D models that have been created for my use over the past 5 years. Looking specifically at one of the models here, you can see from the left on C2 all the way down to the right, S1 in the pelvis. We note things such as a laminar defect in the lower lumbar spine in the black circle. We note the fusion mass that is located from the mid-lumbar spine all the way to the proximal thoracic spine. And obviously the deformity of the spine in both the coronal and sagittal planes can be evaluated three-dimensionally. In this model, we view it from the posterior, anterior, and sagittal perspective. This is a patient with neurofibromatosis. And you can see dural ectasia that's expanded to dissolve the posterior lamina throughout several levels in the cervical thoracic region, and created a basically spinal dislocation and bayoneted spine in the anterior and sagittal planes. So again, the fine details of this very severe deformity are quite illustrated through this 3D model. We also can basically take this model and evaluate it in real time, obviously, rotating it in all dimensions, getting a firm view of the spinal column, something obviously we cannot do intraoperatively in the spine, but we can do this pre-op through this model. What are the benefits seen by using these 3D models? Well, we become familiar with the posterior anatomy prior to the dissection, again, referring to things like laminar defects and fusion masses. We can understand the 3D deformity in real-time pre-op. It's especially helpful in revision patients, those with fusion masses, and also those with congenital deformities. We can also plan our complex 3-column osteotomies going from posterior spine to the anterior spine on the model in real time. We also can have our pedicle screw starting points marked out before surgery. This can help with freehand or even navigation screw placement. We understand the pedicle size and deformation on the model even better than a CT scan. And some models can be created that actually you can simulate performing the surgery on prior to going to the operating room, which is great for trainees as well. So here's a model, basically, from left is cephalad, right is caudad. You see the red dots that I've placed on all the potential pedicle screw starting points, which are complicated not only by the deformity in this model, but also by the long fusion mass, which distorts some of the posterior anatomy. So again, we simulate this pre-op, and we have this model in a clear plastic bag, sterilely wrapped in the OR to use it intra-op as our navigation tool. So I place all my screws freehand, no matter what the condition, using these models. We recently published a paper on the utilization of these 3D printed spine models for freehand pedicle screw placement in complex spinal deformity correction, where we evaluated 513 freehand placed pedicle screws from T1 to S1 in 23 patients. Overall, we had a 96% accuracy and acceptable position according to preoperative plan on post-op CT scanning, and should be intra-op CT scanning. And we concluded that these 3D printed models can make freehand pedicle screw placement safer in severe spinal deformity cases with acceptable accuracy and no neurologic or vascular complications encountered. I'll go through two illustrative cases of how we use these models to make spinal deformity surgery safer. In case one, this is a pediatric revision kyphoscoliosis case. This patient, an 18-year-old male, presented following 20 prior spine surgeries performed in an outside institution for early onset kyphosis, now with severe progressive kyphosis and shortness of breath. Here's his pre-op sagittal MRI scan showing the tenting and stretch of the cervical thoracic spinal cord over the apex of the severe cervical thoracic kyphosis. Here's his 3D CT scan showing the anatomy from the anterior and sagittal perspective. And in more detail, here's his 3D printed model, showing again on the far left, posteriorly, he's severely rotated such that during posterior exposure, you're entering into his foramen because of the severe rotational malalignment. The anterior perspective is seen as well as obviously the sagittal perspective from the right and left sides respectively. He underwent a posterior procedure from C2 to L3 with a 2-level apical thoracic VCR. Here are his pre and post-operative AP and lateral x-rays showing the instrumentation placed as well as the correction obtained following his VCR procedure. He did very well post-op without complications. And here are his pre and post-op clinical photos demonstrating the dramatic improvement in his severe cervical thoracic deformity. The second case is an adult primary kyphoscoliosis patient who had neurofibromatosis and presented with severe pre-op myelopathy. Here's his pre-op AP and lateral x-rays demonstrating severe thoracic kyphoscoliosis with vertebrae that are almost uninterpretable due to his severe deformity. His pre-op sagittal MRI demonstrates the severe thinning and tenting of his spinal cord at the apex of the deformity with cord signal change. Here's his 3D CT scan showing a severe deformity. And again, the 3D printed model, again, from top left at C2 to bottom right, L4, demonstrating the markedly severe kyphoscoliosis. Well, impressively, when we look at his vertical model and measure the distance from the inferior aspect of T2 to the superior aspect of L2, it's only 2.5 centimeters in height. I want you to think about that for a second. That's his entire height of his thoracic cavity preoperatively. So following halo gravity traction, he underwent a posterior procedure from T1 to L4 with a 3-level thoracic-based VCR for a very nice correction of his severe thoracic kyphoscoliosis and marked improvement of his trunk height is seen both radiographically and clinically. He also did very well without any complications postoperatively. So in conclusion, we have used 3D printed models for over 20 years to help plan and execute complex spinal deformity surgery. The pre-op planning assists in individual vertebrae analysis and overall deformity description. Pre-op planning and intra-op execution of both pedicle screw placement and PSO and BCRs are also benefits gained from the 3D model. We find this as a useful adjunct no matter how surgery is performed intraoperatively, either freehand or navigated screws, and can only help understand and perform these complex operations. And I thank you for your attention.
Thank you very much, Dr. Lenke. That was a wonderful presentation, and those two cases were amazing. Any questions? We will allow 2 questions from the our panelists here. Dr. Lenke.
Did you use 3D printing for preoperative planning only in these cases, or did you also use customized implants or drill guides to help in the insertion of pedicle screws?
No, as I mentioned in my talk, for the last 20 plus years, I've placed every single screw through freehand techniques. Again, with or without a model. I don't make a model obviously in every case. Normal idiopathic scoliosis with a 75-degree curve without any anomalies, I do not make a model. But again, obviously, the more complex the deformity, the more often I am to create a model. And honestly, it's interesting that my fellows always prefer to have a model, even on more simple cases of deformity. They prefer to have it because they can study it and again truly understand the 3D dimensional deformity pre-op. Even if the vertebrae are quote more normal, it still I think helps them understand and comprehend the true lordoscoliosis that occurs at the apex of an idiopathic curve, and things that we assume that everyone understands, but some of the trainees, especially some of the neurosurgical trainees that we have now that don't have the same orthopedic background when they start a fellowship, they truly appreciate these 3D models from the deformity perspective.
Thank you. Any more questions?
There's a question in the chat box. The printing of models with pre-existing implants, is it a challenge?
Yeah, it is. And so actually sometimes this week alone, actually, I had a very complex case with multiple previous surgeries and implants in place with pretty much a solid fusion. I actually, the patient I was going to put the patient in halo traction. So while placing the halo, I also took out the implants while the patient was already, anesthetized. So and for the sole purpose really of creating a better 3D model, because you're absolutely right. The artifact, just like we see on a regular CT scan, the artifact does limit the quality of the 3D printed model. So occasionally I will take out the implants in preparation for creating the model and then preparation for doing the revision surgery.
Right. And there is a question regarding your method of that you wrap them in plastic, whereas these models in India, we are sterilizing them with ETO or plasma. Why is that?
I honestly, that's what I wanted to do, but my OR, both in St. Louis and now in New York, will not let me do that. They said for some reason it doesn't pass their quote sterility test of the committee that assesses things like that. Even though the company that makes the models feels they're able to be sterilized appropriately, my OR committee won't let me do that. So I'm not going to argue with them. I put it in a clear plastic bag. It works very well, but yeah, for some reason my OR committee won't let me do that.
Dr. Lenke, there are some associated questions which are there in the chat box, but which are not directly related to this specific talk. I would be grateful if you could answer it. And in the meanwhile, I would like to move on to the next talk, and that is from Dr. Neil Anand, who is going to talk about single position surgery.
And okay, so good morning from the US and good day wherever you are. First of all, it's such a delight to be invited and see all of you. Really miss you guys, and I'm glad we can see each other this way. So, single position surgery, this seems to be a huge topic all of a sudden. And I kind of want to set the stage as to why we're even talking about it. And these are my disclosures where we are. And really, what is single position surgery? In simple terms, just the idea that we can do a 360-degree fusion in one position rather than flipping the patient. That's all it truly is. And you can ask yourself, why is that a big deal? And we can sort of talk about it because I agree, I don't think it's a big deal, but it has become a very common topic of discussion of late. And I think the reason it's happened is one, because of lateral fusions. A lot of us are doing lateral fusions in the lateral position, and call it what you want, the numerous names that have come up with it. And then today we have navigation, robotic assisted placement of screws. And I think the combination of the two has led to this topic or genre of single position surgery, because the idea that we could now do it in one position with these technologies that are available today. And I think that's what sort of led to it. And there seems to be this talk and drive leading to it. But why is it even important? I think, does it really change something? I think the biggest thing it is probably improves operative time and efficiency. But then let's see to what extent. This is directly from this paper. And you can look, what really changes is basically that part of the flipping where you got to take everything off, redrape the patient, obviously bring a new OR bed if you're going prone or Jackson table. And you are reattaching lines and neuromonitoring leads and so on and so forth. And it's anything between probably 30 to 40 minutes in terms of the time spent, depending on how efficient your operating room is. I'm sure some places in 15 minutes you could do it. So it's something you need to ask yourself, how much you're really saving. But anytime you look at the data, it does seem to be in operative time, as you can see, it's 103 minutes in single position. And you flip, it's about 307 minutes on average. And I think it's a little excessive, but I think there's somewhere between 30 to 40 minute difference I think you could make. And in terms of the correction, we seem to have a similar correction, whether you do it in single position or flip the patient. And complications, again, seem to be pretty similar. But interestingly, ileus was significantly more in the flipped patient than someone who had anterior lateral and then was flipped to posterior, which is sort of interesting and pretty high, actually, 0 and 5.54%. The rest of it are reasonably the same, I would say, across the two. So again, here's another one versus lateral and then prone positioning. Another paper, similarly, same thing, where you're again looking at essentially operative time being about 44 minutes longer if you flip the patient. And I'd say you can ask yourself, really, is that such a big deal? But that's something I think each one of us can decide. Is it that important for you to go to a new technology and do it? Or are you okay flipping it, depending on the efficiency of your OR? And we can discuss that, what a big difference does that truly make? So here again, the same thing, you can see the operative time here is somewhere in the vicinity of 40 minutes. So the average is 30 to 40 minutes. So if you again look at another paper looking at that, again, same thing you're seeing is that same difference. So most papers are exactly the same in terms of the time limit. That seems to be the real difference between the two. Efficiency-wise, it seems to be good enough. We seem to be getting the same results. We seem to be getting the same correction and seem to be doing the other things. So just a case example of how we go about it. I've certainly done a few of these. Am I a big fan? I'll openly say I'm not. I don't see a big difference between the two. And I think time will tell whether this will really stay over the course of time. And this will be a straightforward case where we had 4551. 51 is really degenerated. 45 had a spondy. And you can see the MRI there, if you will. That's the 45 axial MRI. And here's the CT scan. So it was indicated for a 2-level fusion, severe back pain and leg pain. You can see the axial with the sublux at 4-5. And so we indicated a 2-level fusion. So we had the robot assisted, self-navigated robot. And it was easy to sort of plan the screws out pre-operatively on a CT scan. I gave a talk on robotics a couple of days ago at your meeting. And so we've been using this really in pre-op planning through your pre-op CT scan. And so what we normally would do is use the robot to place the guide wires in the spine in the lateral position. The patient's in the lateral position. My co-surgeon is literally doing that while I'm doing the lateral approach at the same time. So that again is a little added advantage. You save some time in surgery itself. You can have two teams working simultaneously. So the robot's helping put the guide wires in. The guide wires are already in place, and then we do the lateral fusion in the traditional lateral manner. And you can see here's the A-lift being done in the lateral position, A-lift graft being placed. Similarly, you do your lateral interbody fusion at 4-5. And here's the interbody at 4-5 going in. So you've done your interbody fusions here, and now you can go back to put the screws over the wires that are already placed. Again, all quickly at the same time as I'm literally putting the last device in, the screws are already going in the back. So again, you save sort of another 10, 15 minutes, I guess, in doing this. And it's all percutaneously, minimally invasively done. Rod is threaded in, put in position, and you can get a 2-level fusion done in a single position manner. So yes, it's sufficient. Yes, you save some time. Time will say, are we getting the appropriate lordosis we really need? Would I do it for multi-levels? No, we'll talk about that later. For me, it's really a 1 to 2 level surgery, even 3 levels. I'm a little reluctant. I've done 1 3 level. I usually don't unless I got good alignment already in place. So here's a CT scan of him to show screws in place, and that's your post-op x-rays. Another place I found really useful, another technology that I'm finding useful now is someone who's already had screws placed. This is just to go historically. That's a Delisys, by the way, placed in 2005 with a fusion at 5-1 and a non-fusion at 4-5. But as you can see, the years went by, went on to an auto fusion at 4-5. But she was doing great for 13 years and literally came back with adjacent segment disease at 3-4. And that's what we did. So now we got an adjacent segment 3-4 that's unstable, stenotic, and you got screws in the back. We don't even have the tools available today to remove the Delisys. I literally would have to hack that out. It is already out of the market. And even if I had it, it would be a huge adventure to take this out and put that in. So it's another technology that's available today. And since you're talking of the future, this is rather interesting. And I've used that quite a bit. And here's a CT scan to show you the same thing. Solid fusion, 4551. Here's a clinical status, the severe back pain, urogenic claudication as you'd expect, EOS films. This is a technology that's actually a spinous process fusion clamp, not to be confused with an interspinous process spacer. Very different. It's actually a fusion device. And just to quickly talk about it, it goes right percutaneously between the spinous process through the interspinous ligament, but keeping the interspinous ligament intact. It's in the interspinous space. It actually has room for grafting. That's what it basically looks like. It's a clamp that goes across. And it, as I said, in the same lateral position, once we've done our lateral, we're able to now do, this is just a quick animation of what really happens. The lateral fusion goes in as we would go, and then you literally get a guide wire between the spinous processes in the lateral position through the same incision, another small 1 centimeter incision, dilate down to it. There's a broach and a reamer that creates the space between the spinous processes. Basically, it's a pure adjunct to your lateral fusion. As we know, lateral fusion by itself, standalone, works 89% of the time. It is just to bump that 10% more, give it a little more stability, at least in my plan, to allow that lateral fusion to heal. So I want to make that very clear. We're not using this as a fusion device by itself. It basically is an adjunct to a ALIF or a lateral interbody fusion you've already done, just to give you a little more stability to allow that fusion to occur. As you know, standalone laterals don't do as well. You got a 10-15% non-union rate. So that's what it really looks like. And let me just go off to the next slide. So it turned out to be a really good way to do a stabilization fusion and adjacent segment without ever touching your previous screws. And again, it's a very efficient way to do that. It changes the way we do it. And to me, these are technologies that help us in the long run. And similarly, you can see the 2-year post-op CT scan, the lateral fusion has gone on to heal solidly. So this was just something good for this patient, I think, was a good way to tackle it. And I find this useful for adjacent segment. Here's another patient, and we see this all the time, adjacent segment screws. But otherwise, you're going back to take those screws out or domino, it just changes the operation. And this suddenly becomes a big game saver. So at the end of the day, yes, operative duration is probably important. I think we're increasingly getting data now how OR time singularly may be one of the biggest reasons for our complications. And this is just a paper on single level lumbar fusion. And you can extrapolate that to multi-level big surgeries. And when you go beyond 5 hours, 9-fold increase in surgical site infection. 9-fold. So, and this is a single level fusion. So I think we can sort of extrapolate where we are 10 times wound adhesions. So I think there is some truth to cutting down operative time, being more efficient. And that's where, to me, single position surgery is sort of making sense. Where am I today? 1 to 2 level. I think an MIS TLIF is the best single position surgery. You're one position prone, take care of it. Or do your lateral and navigated percutaneous screws robotic. If it's greater than 3 levels, usually I'm staging them and doing laterals in 2 days later, perc screws like we published from not on it. If it's an adjacent segment, I found this percutaneous interspinous fusion clamp really useful. We've done about 9 now, so we'll talk about it as long-term results. And if it's spinal deformity, as you all know, without a question, it's staged, and I will not do a single position beyond 3 levels, but I really don't think you can get the alignment you need in that sort of position. Thank you.
Thank you, Neil. That was eye-opener in terms of something different happening all the time as far as spine surgery is concerned. Whenever we visit you, we see you doing something new. We are always trying to catch up with you. You do something new, we try to catch up. We probably catch up in 3 years. By that time, you're doing something else altogether. Let me put the question, or I mean the talk open to the house. Any questions? We will take 2 questions from the panel. Well,
so you are doing these surgeries in the lateral position, Neil. There have been some publications where they're encouraging prone position, single position surgery also. What is your take on that?
I've never done it. I have no experience with it. I know exactly what you're talking about. And like I said, it's become almost a mantra now that everybody jumping on the single position surgery. And as I said in the beginning of the talk, I'm not sure why such a big deal is being made of it. I think there are other incentives for that. Honestly, I don't believe it's a huge difference. If you're efficient in your OR, as I'm sure many of you are, you probably can do the same job well. So as long as we can get the job done and do what we need to do, and it's safe, I think it's fine. And so I'm looking forward to results on that technique. I certainly know what you're talking about.
Right. I think time to move on. Thank you very much, Neil. That was a wonderful talk. And we move on to the next talk. And we have Dr. Aditya Gupta taking us to the future of neuromodulation. Where is it headed? I'm sorry, neuromonitoring. Where is it headed?
Neuromodulation. Gautam, it's neuromodulation.
Yeah, where is neuromodulation headed? What is the future? And we've got Dr. Aditya Gupta talking.
Good evening. Thank you so much for the kind invitation to participate in the ASECON, and thanks to the ASECON organizing committee and Dr. Chabra specifically. I'd like to be talking on neuromodulation in spine care. And as we know, neuromodulation is an important modality which helps us out in different scenarios. And what we have available with us is spinal cord stimulation, dorsal root ganglion stimulation, and some intrathecal drug delivery systems. But I would basically be talking about spinal cord stimulation. Now let's begin with spinal cord stimulation for pain. This has been in vogue for almost 5 decades, and the initial use was developed by Sheely et al. In 1967. And basically, to put it simply, it depends on the inhibition by the large diameter sensory fibers which exist in the posterior column. So basically, posterior column was the first site of stimulation, and large fibers exert an inhibitory influence on the dorsal horn of the cord, which is really the main pain area. So the concept, as I have mentioned it here, is that dorsal horn of the spinal cord is the main sort of gate pathway which controls the propagation of the pain impulses to the brain. And what happens in spinal cord stimulation is that stimulation of the dorsal column results in action potentials which go spread to both the directions. So they go to the dorsal horn and also orthodromically in the rostral directions to the supraspinal centers. And therefore, spinal cord stimulation really acts on multiple sites within the neuraxis. Now, in the Indian scenario, it is less practiced despite many good results reported from the West. And probably the two main culprits are the high cost and the limited availability and awareness about this technology. But I think of late, it has certainly started gaining popularity. Now, spinal cord stimulation for pain, the main indications are failed back surgery syndrome, and there was a good trial for this in 2005. Chronic regional pain syndromes is a very, very big disease category in which spinal cord stimulation really does wonders. Apart from phantom limb pain syndrome, neuropathic pain syndrome, and also some ischemic pain syndromes coming from peripheral vascular disease and even intractable angina. Now, the other uncommon indications we'll be touching briefly are spasticity, paraplegia, bladder control, and neurogenic incontinence. The basic contraindications for the spinal cord stimulation are the presence of an organic lesion like a spinal stenosis or instability, which produces the pain. Presence of infection also is a relative contraindication because one would not like to put implants in the presence of active infection. Patients who have severe psychological issues and substance abuse are also precluded from this because this needs a regular follow-up and evaluation. And of course, any patient who has contraindication to a surgical procedure per se, like a coagulopathy, would be a poor candidate. Now, this is a patient assessment for spinal cord stimulation, and really the attempt is to weed out patients who have one of these contraindications. So I will not go into this in detail. The device has basically three components. One are the different kinds of leads. Then there are connectors. And finally, there is the implantable pulse generator. Now, apart from these basically three things, there is also an external programmer which is available to the physician to dial up or dial down the amplitude and the frequency of the stimulation. So the leads come in different sizes and varieties, and there are three main vendors as the slide will show you. And of course, these are the implantable pulse generators, and the ones which are in vogue currently are the ones which are rechargeable ones. So they have a life of at least 15 years, and they can be recharged easily by the patient at home, typically on a weekly basis. So these are the patient programmers, and the exciting advance is that some of this programming can even be done remotely by a pain physician. So in the procedure workflow, there is a trial lead placement in which we put percutaneously 2 8-channel leads, and these are like wires, and the patient is paced for a week using an external stimulator, and on a successful trial, then we do the permanent lead placement. So these are the typical steps of a lead insertion in which a lead is passed through a 2He needle, but I would rather take you through a short video to bring home the salient points of the surgical procedure. So this is the introduction of the electrode through the needle. And on the AP view, important thing is to check the trajectory of the initial few millimeters of the lead, which we check periodically both in the AP and the lateral directions. And sometimes we find the lead is not going freely in that it sometimes gets stuck in the anterior epidural space. So we want the lead to be in the posterior epidural space. And in that situation, it goes freely. And the other important thing, it has to be paramedian on one of the sides. So typically in trial stimulation, we put in 2 leads, and that has certain advantages for achieving pain relief. And repeatedly, we check the position of the lead as we keep on advancing it. And here you will see that a good length of lead has been inserted, and we introduce through a separate entry wound for the other side so that you have these 2 leads with the electrodes staggered with respect to each other. That increases the field of coverage of the stimulation, and that is the ideal final lead position. So these are the typical lead stimulation parameters. The burst suppression is known to be the most effective, and this is what is being used by majority of these systems today. And the results are actually very good. For failed back surgery syndrome, there is a level 1 evidence of the efficacy of spinal cord stimulation across the randomized controlled trial. And for the complex regional pain syndrome, there is again a level 2 evidence but several trials have noted that a dorsal root ganglion stimulation may be more beneficial than a spinal cord stimulation. So as with any implantation of a pacemaker or an implant anywhere in the body, there are typical complications which are mentioned. Whenever we use these implants, which are neurostimulators, there is a definite risk of electrode migration, breaking, and basically with a higher degree of stimulation, patients sometimes have some painful paresthesia. So that basically means that the stimulation has to be reduced. Now, coming to the second point, spinal cord stimulation for spasticity, that is something which has been investigated quite a bit, and there is conflicting data. And basically, there are mixed results from various studies, but there has been some recent interest in use of spinal cord stimulation for spasticity. This was a Russian study in 2015, which showed that the effect of spinal cord stimulation is very good for spasticity. But since then, if one analyzes the other published literature, there is a recent study, not very recent, but 1981, in which for 160 patients with cerebral palsy, 94% showed improvement in spasticity. So for spasticity, I would say it's a mixed bag. I would not really propagate purely for spasticity, but yeah, a patient who has pain and spasticity probably would be a good candidate for this. Now, spinal cord stimulation for paraplegia is a very new, exciting use, which is being very actively investigated in United States, Europe, and also in our country to a limited extent. It's not FDA approved, but there are very, very encouraging anecdotal case reports of how voluntary movement can be achieved in patients who have spinal cord injury. And this needs, of course, a detailed evaluation and also a detailed physiotherapy post-stimulation. And basically, time doesn't permit me to go into this in detail, but this is probably one of the most exciting uses of spinal cord stimulation. Now, finally, a few words about spinal cord stimulation for bladder control. This is something which is being used clinically for patients with spinal cord injury, and with a very, very promising data coming out. And retrospective and prospective studies have shown that majority of patients do exhibit significantly alleviated symptoms post-spinal cord stimulation. And there is even a report which says that it may even help the bowel incontinence in patients with spinal cord injury. So to conclude, spinal cord stimulation and neuromodulation in general is an established modality for chronic neuropathic pain, but its efficacy in spasticity, paraplegia, and neurogenic bladder is yet to be established, although it is very promising, likely to find wider use, but economic limitations in India compel us to ethically and carefully select these patients. Thank you so much for your patience.
Yeah, thank you, Dr. Aditya Gupta. Just one quick question. Are the electrode placements for when we use it for spasticity different from that when we use it for pain?
The placement of electrodes is not remarkably different. Basically, you put the electrodes on these segments which are showing the lower motor neuron manifestations, because below that will be segments which will be generating spasticity. So the levels are basically not very different. It just depends on the exact level of the injury, and you basically put it across the segments which are showing you the lower motor neuron kind of manifestations.
Any other questions? Gautam, you are muted.
Is there a time limit within which you would recommend that if a patient with paraplegia comes with a neurogenic bladder, should he come within the first 3 months after the problem? Should he wait for 1 year, 2 years? How soon should he be treated with this stimulation?
So for sacral nerve stimulation, the best results are within 1 year of the injury.
Okay.
And obviously, for the first 3 months, we don't really gun for these kind of implants to take place because we want some spontaneous improvement to happen. And most of our patients pay for this stuff out of the pocket. So I would say within the first 3 months, maybe better to evaluate and wait, spend the time and carefully laying out what kind of bladder dysfunction the patient has, but definitely do it within the first 1 year.
Thank you very much.
Yeah. Just one quick question. I was under the impression that this for sacral root stimulation, this has mainly an action for hyperactive detrusor.
Yes.
Whereas when it comes to bladder neuromodulation, the real one is the Brindley stimulator, right? Rather than the one that you demonstrated. Would you tend to agree with that?
Yes, I agree with that. And I must also confess that as a neurosurgeon, I do not have much of personal experience with using it for continence, to be honest, because my major practice and my major use is basically for the pain.
So thank you very much, Dr. Gupta. And
thank you so much for having me.
Yeah, and we move on to the next talk, and that is on targeted and molecular therapies. And we have Dr. Prabhat Bhargava, who's going to speak on this topic. Dr. Bhargava, all yours.
Good evening, everyone. This is Dr. Prabhat here from Tata Memorial Hospital. I am a medical oncologist in Tata Hospital, Mumbai. Today, I would like to thank the organizers for giving me this opportunity to present to you the targeted therapies in cancers. I will start my talk. So, giving you a brief introduction, we all know the stem cells are the reserves of our body, and they are used whenever it required, and they can specialize in whatever cell type the body needs. Like when blood is deficit, it transforms into RBCs or platelets, and thereby we can replenish our body requirement and maintain a hemostasis. Similarly, cancer also has stem cells, and not that all the cells are dividing at one point of time, and that is the reason why we have recurrence in cancer. The conventional chemotherapy can only kill those cells which are dividing, because they go and act only on the dividing cells. So there was a need to improve the outcome of cancer, and further improvement is in the form of targeted therapies. So before understanding targeted therapies, let me take you inside the cell. So this is a cell membrane, and these are the receptors on cell membrane. Once there is signaling on the receptor, signal is received, the cell starts send signal inside via the various signaling pathways into the nucleus, and thereby the cell proliferates. So when there is a problem in the receptor or in the signaling pathway or in the nucleus itself, the cell turns into neoplastic cell, and thereby keeps on replicating even without the signal. So this is a diagram of a melanoma, of mutations that are seen in melanoma. So we can see one of the example is c-KIT mutation, which is mutated in 0 to 39% of the melanoma, or NRAS may be mutated in around 20% of the melanomas, and so on and so forth. So what are the targeted therapies? What in targeted therapies are we doing is when we know that the c-KIT is mutated and this is overactive, leading to proliferation, sending downstream signals in the cell and into the nucleus. So why not inhibit the c-KIT itself, the mutated c-KIT? Or if we cannot inhibit the mutated c-KIT, why not inhibit NRAS, so that even if the c-KIT is mutated, the further signaling will not go downstream, and thereby the cell will not proliferate, and leading to the inhibition of the cell proliferation. So these are the various examples of inhibitors or targeted therapies that are being in the pipeline or being approved. So the first targeted therapy, why I chose melanoma, is because imatinib is among the first targeted therapy to be approved in cancer treatment, and it has done wonders in cancers like CML, where around 70 to 80% of patients are doing well since 5 to 10 years on oral tablets. Their cancer is controlled just like the way we control diabetes, similar to something like this. So this imatinib is a specific inhibitor of BCR-ABL, PDGFR receptor, and c-KIT tyrosine kinase, and produced by the genes which are responsible for growth in CML and GIST. It is effective in CML, GIST, melanoma, wherever there is c-KIT expression. Side effects compared to chemotherapy are very minimal: nausea, myalgia, edema, diarrhea, myelosuppressions, and sometimes deranged LFTs. So you can see a drastic difference between a GIST patient who was given for 2 months imatinib. You can see this is what a huge GIST lump he had, and within 2 months how it disappeared as the proliferation had stopped. Now coming to second one, This is breast. Breast, you would be seeing many breast patients present with bone pains because they commonly present with bone metastasis. This is one of the pathway which is active in breast cancer, HER2. HER2 is also lies on the cell membrane. Why it is commonly over amplified in around 15% of the breast cancers. Once over amplified, this does not require signaling from above, and it keeps on sending signal downstairs, and thereby the cell keeps on proliferating. So what we did, what the scientists did, was to inhibit the HER2. So the first and foremost drug which was found was trastuzumab. This is a humanized monoclonal antibody specifically inhibiting HER2. It either binds extracellularly on this subdomain 4 of HER2, and thereby flagging them for destruction by immune cells, or it inhibits the dimerization of HER2, or it can inhibit the signaling, downstream signaling. So this is monoclonal antibody. Now, how do we further improve the therapy by this monoclonal antibodies? By flagging them with the chemotherapy. So this monoclonal antibody trastuzumab is now linked with various types of chemotherapy. So once the monoclonal antibody binds to the cell, the chemotherapy is selectively delivered to the cancer cells, thereby targeting only cancer cells and sparing the normal cells by the side effect of the chemotherapy. This is another way how we have improved the targeted therapy, by just targeting the cells, chemotherapy directly to the targeted cancer cells. Even after this is breast cancer survival over the period of years. When there was not even surgery was found, the survival was minimal compared to more and more patients are surviving as and when we discovered that only mastectomy, further with chemotherapy followed and anti-estrogen agents, and now with targeted therapy. But however, we still know that not all 100% patients are surviving. So there are reasons why targeted therapy is also failing, that we will come to in later subsequent slides. Let me come to breast cancer, lung cancer. So this was a patient who was treated with geftinib. Till that time, it was not known why the drastic response came to this female with geftinib. Later on, it was found that the selective response was coming only in few patients, and this was those patients who had EGFR mutations. So further molecular testing revealed now that lung cancer is not just one cancer, but it can be subdivided into various types, like squamous cell carcinoma or adenocarcinoma. This adenocarcinoma can further be subdivided into so many subtypes, where KRAS is more common in smokers, and still therapy is undiscovered, is discovered, but in initial phases of clinical trials, while EGFR is more common in our South Asian females. It is found in 17% overall. And this is how we can divide cancer, lung cancer, from histology based to molecular based now. And we have array of drugs to target each of the mutations. This is how. So once we diagnosed a lung cancer patient in stage 4, where we cannot cure them, we first have to wait for this mutation reports to come, and then only we can start them on, based on most of them are oral therapy only. With just tablets, we can control the disease for months to years. This is how targeted therapy has evolved in lung cancer. Further, let me come to further how things are evolving in targeted therapy. So now this is NTRK gene fusion is found in many cancers. In lung cancer, it is only found in 0.3% of the cancers. So these two therapies have been discovered, entrectinib and larotrectinib. And this is how, when we give a patient of 55 patients were given with NTRK fusion, were given larotrectinib, the response rate, this is how it is seen depicted in a waterfall plot. You can see many patients achieving 100% response with larotrectinib, followed by 90%, 80%, and very few patients progressed on therapy without showing any response. So now further and further targeted therapy may not even require what is the diagnosis of cancer. It will only require what is the mutation going on in the cancer. This is a perfect example, which is upcoming still in phase 2 trials, and phase 3 trials are still awaited. Are this, as I showed, imatinib also has few side effects. Are this TRK inhibitors very much having very significant side effect? No. You can see most of the grade 3 side effects are less than 1%. Very few are only transaminitis was seen in grade 3. Similarly, with entrectinib, only 5% patient had weight loss. Otherwise, most of the side effects are less than 3% of the population. Another way is to target those antigen on the cell and may generate the T cells of the body to target this antigen. So these are this is the slide of B cell membrane antigen in myelomas, and how are we further, how is the targeted therapy evolving. So we can, these are chimeric antigen receptors on the T cell. The patient T cells is drawn out in the blood. They are infected with lentivirus, which has cells to recognize tumor cells as foreign body. This is injected into the T cells. These T cells are proliferated in vitro, and then they are injected back to the patient, so that the patient's T cells, this artificial T cells, will recognize tumor cells as foreign body and target these tumor cells. So the process is remove these T cells from the patient's body, deplete the normal T cells in the patient's body, and then after proliferating this T cells, these artificially manufactured T cells, they are injected back into the patient's body, and thereby attacking the cancer cells. So is targeted therapy, what I have demonstrated, so good enough? No, the truth is the patient's cancer cells are initially dependent on one pathway, but if you keep on blocking this pathway, it will go on to the second pathway, and if you block the second pathway also, it will go on to third pathway. So most of the targeted therapy are able to achieve response only for a limited period of time, and later on we lose the response. So just targeted therapy is not enough, and maybe we will need further therapy to improve the outcomes of the patients. So conclusion, targeted therapies which improve the therapeutic index are future of anti-cancer therapy. Advances in molecular pathway will provide the means to identify the targets and will be used to subtype tumors, and will predict response to therapy and provide prognostic informations. Thank you for your patience listening, and I'm open for the questions. Thank you.
Thank you, Dr. Bhargava. That was amazing. I'll open the house with two questions to you. The first is, how does this molecular therapy translate in terms of how we plan our surgery? Because what happens is, when we think about surgery, we think about patient survival in a metastatic tumor. So is the survival 6 weeks? We probably won't do anything. If the cervical bill is 6 to 3 months, we'll probably do a simple decompression or something. So that what happens is that, as per the traditional chemotherapy, these were the goals that we had. Now, with these targeted therapies, I think the survival has significantly improved, changing the normal paradigms by which we judge survival of a patient. So how would you advise us to go about when we think about surgery now in terms of all these tumors, if a patient can afford the all this targeted therapy? That is one. And the second question is that the targeted therapy is great for systemic control of the disease, but the local control at the site of in the vertebra where there is cord compression or anything, what is the role of targeted therapy in local control of the disease? So suppose a patient comes to us with a typical lung cancer with metastatic to the spine, and it's metastatic to the brain. We traditionally would have avoided surgery in such a patient. We would not have touched the patient. This patient is going to die in 6 weeks. Why touch him? Now the question arises in our mind is, with targeted and molecular therapies, are we refusing? If he survives 6 months, we will have made this guy's life miserable by not operating on him. So how should we go about thinking on these issues?
So I would like to quote my sir, my professor. He used to always teach us while he was doing his medical oncology. He used to be taught stage 4 lung cancer, send him home, no survival. And now their survivals of stage 4 lung cancer is also reaching 5-year survival that we normally talk about as 50% of even stage 4, if the patient is affordable for targeted therapies or any molecular immunotherapy, which I have not touched in this my session. So it depends. Your question was right. It depends upon the affordability of the patient. If he's affordable for everything, then even in stage 4 lung cancer or many of the stage 4 cancers, now I will advise, let's go ahead with surgery first. If there is cord compression, which is leading to paraparesis or some focal neurological deficit. If there are no focal neurological deficit, then it will depend upon what mutation does the patient have. And some targeted therapy have an overall response rate around 80%. So in those patients, if patient is asymptomatic, even I will say don't touch right now. If he progresses, so 20% may progress even in targeted therapies, as I showed in my NTRK slide. In those patients, if focal neurological deficits occur, then I will send return back this patient for surgery. Otherwise, asymptomatic patients, we can start them on targeted therapies first and see whether they are in those 80% who are responding with the targeted therapy.
But we have after you and right next to you on the screen two legendary oncosurgeons, spinal oncosurgeons, Dr. Stefano Boriani and Dr. Ehud Mendel, who are going to be here after you. So if you can stay for another half an hour or 45 minutes online, when we question them, I'm sure your inputs would be very, very useful. And I would like to, without much ado, move on to the next talk, and that is from Dr. Ehud Mendel. And he will be talking about what lies ahead, the future of management of spinal tumors. Dr. Mendel, I don't know whether you would remember that we spent some time together in 2005 in Los Angeles at an AO Spine International Tumor Board meeting. And since then, it's been a long time I've not met him. So Ehud, please go ahead.
All right, well, thank you so much for inviting me to give this talk. I'm going to talk about just basic principles and maybe answer some of the questions that came up during the previous session. I really want to thank you guys for inviting me to give this talk. Spine tumor is my passion, and hopefully I can share some of my thought process. And I wanted to start with just basic principles that I follow and then move into some future trends in the management of spine tumors. So I'm just going to show you 5 quick cases that I'm sure a lot of you guys are dealing with patients with spine tumor. See, here is a patient with multiple myeloma, 57-year-old. You can see that there is an L2 pathologic fracture on a patient with multiple myeloma. No neurological deficit, just back pain. Question is, just think about how would you, in your own practice, would manage this particular patient. Here's another patient with renal cell carcinoma, very similar presentation, L1 pathologic fracture, metastatic renal cell carcinoma. Very similar presentation to the multiple myeloma, similar location of pathology. How would you manage a patient like this? And it's the difference between a multiple myeloma L1 fracture or L2 fracture versus a renal metastatic disease with a fracture. Would that make a difference in your practice? Here is a third case. Again, patient just with back pain. All of these patients have no neurological deficits, they just have pain. But in this particular case, you're dealing with an L3 chondrosarcoma. Presentation is the same. Location is lumbar spine in all of these patients. How would you manage this particular patient? Here is a patient with thymic carcinoma. And when you look at the MRI, there's new lesions of T11 and T12. Patient, again, presenting with similar location, lumbar, thoracolumbar mets or lesions with back pain. How would you manage this particular patient? So I'm throwing this out there because I'm showing you 5 cases of patients who are presenting clinically the same with presentation of lesions in the same location. And how would you manage each one of these patients? Do all these patients need surgery? Does the difference between the difference in the biology, the type of tumor makes a difference? And if you do decide to do some surgical intervention, what would you do here? And when it comes to what is available for us as surgeons, we have these options. We have intralesional resection options. We have an en-bloc options. We have adjuvant therapy. Chemotherapy now is, was mentioned before, immunotherapy has a huge evolution. Radiation, stereotactic radiosurgery, and minimally invasive like vertebroplasty and kyphoplasty. And I wanted to present this particular case because I think that ultimately will lead to what I'm trying to deliver here. Here is a young lady who coming to the emergency room who has no diagnosis. And she's coming in with back pain, and she has a little bit of weakness in her legs. And you can see that her exam just shows slight weakness in her iliopsoas. And here is the MRI. And she's in the emergency room, and you guys get called to see this patient. And so where is the pathway of what actually needs to be done with this particular patient? She has very minimal weakness. There is no diagnosis, and she has severe spinal cord compression. So I would like to ask all of you, how many of you will take this patient to surgery from the emergency room, considering some weakness in the legs, considering the fact that there is severe cord compression, but you don't have a diagnosis here? This patient, is few more slides, you can see here the cord is severely compressed. There is tumor wrapping all around the thecal sac, the vertebral body. And ultimately, what I want to show you here is this patient was taken to surgery, and this is what was done. A laminectomy was done, a decompression was performed, and the pathology came back lymphoma. So now that you know, in retrospect, that this was lymphoma, was that the right management scheme for this particular patient? And I just want to throw it out there. So if you, each one of you can think about that for a second. Now let's take, and this is the post-op MRI, then you can see a lot of the tumor is still there. The patient got better after surgery with improvement in the strength, but this was a lymphoma. Now let's take the same case, but instead of 4 out of 5 strengths, let's say she's coming in with very severe paraparesis in the lower extremities with 2 out of 5 strengths. And the question that I have for you again, would you take then this patient for surgery? And the question that I want to throw at you is, how much of a deficit in a neurological exam you're willing to accept and how much you're not willing to accept? And that is where it gets to be a little murky when it comes to taking this type of patient to surgery from the emergency room or not. Here is another case on a patient who comes in with progressive foot weakness and intermittent bowel bladder dysfunction. And this is the MRI. Again, no diagnosis, but in this case, significant neurological deficit with bowel and bladder incontinence and foot weakness for over a week course, progressive in nature. And this is a patient who had no diagnosis, was taken to surgery immediately to decompress the thecal sac, and intraoperative biopsy came back as chondrosarcoma. And once it came back as a primary bone tumor, the patient was followed with stereotactic radiosurgery. His symptoms have all resolved. His bowel and bladder symptoms have recovered. And he's done well for about 3 years, only to then present with that in his skin. And what you see here, he thought that one of his screws is poking up to the back of his back and his construct is failing. And when you look at the MRI, you can see a massive recurrence at the operative site. And you can see what he thought to be a screw where the red arrow is actually a local recurrence right underneath the skin. So, and in addition, yes, he was right, there was a fracture of the rod there. And we ended up taking this lesion out, taking it in some sort of an en-bloc fashion and revise his construct. And he ultimately needed to have a big reconstruction with plastic surgery to be able to close this wound. So clearly chondrosarcoma, primary bone tumor, that was not likely the right surgery to do, maybe for both of these patients. And I wanted to present all these because the take-home message and maybe future trends in spine tumor surgery is that there's some mismanagement related to sometimes the bad timing of operation or operation when you don't have a diagnosis. And so I want you to be aware of the triple W, which is the wrong operation on the wrong patient by the wrong surgeon. And I want to stress again, these are all patients that have multitude issues, and for the sake of time, I'm going to go quickly, but they are immunocompromised, they are nutritionally deficit, most of them are on steroids with multiple of side effects that could be related to it. A lot of them are coagulopathic with thrombocytopenia and platelet count that's low. A lot of these patients are hypervascular, the aneurysmal bone cyst, giant cell tumor, and all long laundry list of patients who are very vascular where you have to think about preoperative embolization. And then, as some of my slides show, you have to think about wound management. A lot of these patients may have seen radiation, and so there's significant issues with wound complications. So, you know, we are upfront, very quickly get plastic surgery involved in order to maximize our ability to close this wound. This is a patient with a sarcoma that presented. Here is another patient with a sarcoma that presented. So clearly we can do big en-bloc resections, but ultimately you have to get multidisciplinary involvement on a lot of these cases, because once you do these surgeries, you got to be able to close this wound. And the surgical plan is very critical as to whether you're planning on curing them or palliating them. Clearly, you got to establish a primary bone tumor for metastatic disease. But I think, you know, one of the future trends and the key aspect for any patients with cancer is make sure you know what you're operating on. Try to make sure that you get biopsies up front before you proceed with any surgery. Those are the kind of things that are very critical. Here's a patient who was sent to me for schedule for an en-bloc resection for a sacrectomy for presumed sacral chordoma with no diagnosis. And as you can see, that ended up to be an ependymoma, which require a completely different surgery. The biopsy is very critical. Make sure that you are upfront with your interventional guys patients like this, you want to stay away from a transoral biopsy or a transrectal biopsy, which would be the quickest way to establish a diagnosis, but then you're unable to remove the track with it. So make sure that you plan your track in such a way that you can include the track to minimize seeding along the track itself, include the track with your specimen, and you can see a couple of examples here where we are including the track with the en-bloc resection. Make sure that those biopsies are done from midline and not done far lateral to not being able to allow you to take this specimen out. We're now moving toward the artifact and carbon fiber rods and carbon fiber screws. And I just want to show what's happening here. When we put in doing all these big reconstructions, when you end up trying to get some surveillance, you can't see anything on all of these reconstructions. So there's now evolution toward moving toward the carbon fiber screws, carbon fiber rods, which then when we follow with the next thing that I want to talk about, radiosurgery, we typically do radiosurgery on a lot of these cases who get separation surgery for metastatic disease. We follow it with stereotactic radiosurgery. And once you use these carbon fiber screws and rods, there is no necessity for myelogram. Typically, with titanium rods, we do myelograms on these patients so that the radiation oncologist can really map all around it. But now with carbon fiber rods and screws, we can rely purely on just the MRI. Stereotactic radiosurgery is very critical for any practice with they deal with a lot of spine tumors. So we have a very robust program at Ohio State where we go through either preoperatively or patients like this. This is a patient with single met, has a little bit of pain. This patient doesn't need surgery, and radiosurgery would be a very good option. Or sometimes residual disease after surgery in critical areas around vertebral artery, things like that, where radiosurgery comes to be very helpful. So we talked about a little bit the intralesional, the radiosurgery. I want to mention the vertebroplasty ward with the vertebroplasty or kyphoplasty, which is a very powerful tool for a lot of these patients. I've looked at a lot of these data all throughout my career at MD Anderson at Ohio State. We did a lot of comprehensive reviews. A lot of these patients are unable to go through big surgeries, but are in a lot of pain. And so we really push the limits on cement injection. Sometimes there's a lot of contraindication or presumed contraindication for bad fracture, canal compromise, back wall that's missing with risk of cement leakage. And we have looked at it and refuted a lot of those proposed contraindications, though these are the things you don't want with cement leaking into the canal or some injections that look like this where cement is just pouring everywhere. Cement, can end up in the lungs, can end up in the brain, can end up in the canal. So you got to be very careful about this. We're pushing the limits about these. A lot of patients that have high C2 lesions, we start looking at transoral vertebroplasties that save them potentially a occipital cervical fixation. This is a case of a C2 renal met with a transoral vertebroplasty was done and fill up the area. So we have looked at our data and actually show that we can refute a lot of the proposed contraindication for cement and that some of these contraindication can really be relaxed. Dr. Boryani obviously talked a lot about en-bloc resection, and these are really the more challenging cases. These are mostly for the primary bone tumors. So en-bloc resections are really to alter prognosis. That's one of my indications for surgery. Spinal instability is critical for the metastatic ward when it comes to if spines are stable or unstable. I'm sure most of you are familiar with the spine oncology study group where we came up and developed these criteria of establishing what spines are stable, what spines are unstable. This is a patient with an L3 met. And if you, for the sake of time, if you end up all the points here, you're going to get to SIN score of 9, which is potentially unstable. Neurological deficit is a third criteria. Clearly, if you have somebody who comes in like this with a huge bone in the canal with neurological deficit, or somebody like this with severe cord compression, these patients would benefit from surgery to help with neurological deficit. And I just want to throw it out there that pain by itself, axial mechanical pain related to fracture that gets better when they lie down, gets worse when they get up, is also an indication for surgery. So just briefly, when it comes to surgery and then future plans, plan it wisely. These are big surgeries. Think about what kind of approach. Here, I showed this slide before on a patient with a huge sacral chordoma. a lot of the mid-thoracic area, we do transpedicular ovarectomies through the back. We ligate the nerve roots. And then Tarush, who was my previous fellow, and I have looked at cement reconstruction versus cage reconstruction. And we found out that the cement reconstruction is a phenomenal workhorse for all those thoracic cases. And there's no necessity to put any cage in the front. The cement works very well. I want to lastly talk about some of the primary bone tumors. Again, these are cases that are challenging when it comes to figure out how to get to the point where you can get these tumors out in one piece. There are lots of techniques that have been described as how to do it. Here is a quick case of a sacral chordoma here. And ultimately what you want is be able to remove this tumor in one piece without entering into it. So the idea about these cases for all these primary bone tumors and some of the solitary mets, like maybe renal cell carcinoma, pancreas tumors, to be able to maximize treatment. Keep in mind that some of them are very sensitive to some radiation or chemotherapy options. So sometimes you want to start with that before you proceed with surgery. So perioperative chemotherapy for the Ewing sarcoma, osteogenic sarcoma, the high-grade chondrosarcoma, the differentiated chordomas, all of these are important. The giant cell tumor have seen huge revolution when it comes to the denosumab, the monoclonal antibody. And I'm just showing you some cases over here. This is a lady, 32-year-old, came in with a giant cell tumor of L3. Just pay attention to L3 completely missing here and broken in the canal. And you can see 3D reconstruction of this giant cell tumor. And in this particular case, I've elected to just proceed with stabilization from the back. And then she was placed on denosumab. And you can see that the bone is completely filled in within 6 weeks. Here is a lady with a pharmacist with neck pain who came in with a giant cell tumor of the cervical spine at C2, broken. We stabilize it from the back. And again, I want to get your attention to the C2 vertebrae that's completely missing and broken. And within 3 months, the entire vertebrae have completely filled with bone. So denosumab definitely revolutionized treatment options for patients with tumor. Just keep in mind that some of those tumors, again, even the primary bone tumor, they require preoperative embolization. Some of them could benefit if you cannot do an en bloc resection with intralesional resection. And when it comes to those that you can do an en bloc resection, Dr. Boriani obviously is going to talk later, but really he was the key person who led our thought process about considering these big surgeries with en bloc resection to be able to resect the sacral chordoma, sacral chondrosarcoma, because the results are, the disease-free survival is what it makes the difference. We do it in the sacral spine, and we can do it anywhere. There's a mid-thoracic sarcoma that underwent an en bloc resection to the back with reconstruction, and you can remove these vertebrae in one piece and create a very nice chance for this patient to actually be cured of cancer.
Dr. Manuel, can you sum up, please? We are running a little late.
Yeah, so I'm going to skip on the sacral lesions. Sacral lesions really require a different thought process. Just want to throw this out there that on the sacral lesions, there are lots of techniques we have developed for placement of wires in the belly that allows us then a quick resection of these sacral tumors, pulling the wires to the back, and then perform a sacrectomy and be able to remove these tumor quickly in one piece. And we have published it trademark technique. And there is the last case here on a huge chondrosarcoma that again, we looked at ability to increase the rate of fusion on a lot of these cases where we actually reconstruct these with autologous bone graft in order to maximize our fusion. And all of these patients has massive fusion at the end of these cases. And you can see right here where we use this vascularized graft to close the pelvic ring. And this patient within 6 weeks to 2 months, you can already see bone growth that's going. So, we sacrifice the limb. These patients already presented with significant deficits. We are able to use the bone, vascularized bone graft that's intraoperative pictures with the vessels. And then we are able to implant these in to close the pelvic ring itself. We get nice fusions and, these patients are actually doing pretty well. I just want to throw the last thing about our cancer engineering program. This is a huge team where we are looking at personalized models for patient, 3D modeling, vertebral fracture predictions with animal models and en-bloc characterization. This is some of our personalized models for patients, including patients with cancer, where we, similarly to what Dr. Lenke discussed, we're doing it now in spine, where we create the tumors, we can create 3D reconstruction of these models, and that allows us then to do a lot of the stuff up front as to the extensive reconstruction that we need, how many levels above, how many levels below. A lot of this stuff is done through supercomputers through the university to create modeling of the spine. And with 3D modeling, we can create now complete vertebral bodies that are perfect fit for these en-bloc resection, where this is patient-specific vertebral bodies. We can create hemisacrum 3D modelings to fill in those huge gaps that are left once the sacrum is being resected. And then we are looking at different shape modeling for a lot of these patients using artificial intelligence and actually trying to create modeling of the spine and try to predict fractures after radiation and whether there's some role for prophylactic vertebroplasties to prevent further fracture of this vertebra after. So in conclusion, the management is challenging. These surgeries can restore and protect neurological function, improve pain, and a significant impact on quality. The key is really to understand the biology of spine tumor, which is critical in defining the goal of treatment. And surgeons who are dealing with this spine neoplasm should be familiar with various surgical approaches, as well as complex anterior-posterior reconstruction. So be godly, try not to be God. And again, thank you for your invite, and I'm open to any questions.
Thank you, Dr. Mendel. There are a number of questions which are there on the chat box. I would be grateful if you could stay back for 5 minutes and answer them. We are running 20 minutes late, so I'm afraid we'll have to move on as it is. Dr. Boriani has been waiting for quite some time. So thank you very much, Dr. Chhabra, Dr. Shankaracharya, for moderating this fantastic session on the future of spine surgery. And I thank each and every speaker from across the globe who has come and enlightened us on what spine surgery and spinal management of spinal problems is going to be over the next 20 years. So I think we've learned a lot. We've enjoyed this session tremendously. Thank you, Dr. Chhabra, for thinking about it and organizing this.